we are having also for pharmacology. Okay, so can you see my slides? Okay, so today our main topic will be, we will be mainly discussing about in cell injury, inflammation, and some topics about immunology. Okay, so today's first topic is cell injury. So can you tell me what is the most common cause of cell injury? So since we are doing it as rapid revision, like quickly we will revise the important topics only. So please answers, and I will also write it. We will discuss only most commonly asked topics, or I can say PYTs, previous year topics only. Okay, so what is the most common cause of cell injury? Most common cause of cell injury will be, anybody can answer? I cannot. Okay. So most common cause of cell injury is hypoxia. What will be the most common cause of hypoxia? It will be always be ischemia. Okay. So whenever there will be any obstruction to the blood supply, there will be ischemia. That ischemia will lead to the hypoxia. Okay. So what is the most sensitive structure in our body which will be most sensitive to hypoxia? I can say that is our neurons. Okay. So for the neurons, the ischemic time is only 2 minutes. For most resistant structure which is resistant to hypoxia, that will be our fibroblasts. Okay, fibroblasts are the most resistant for the hypoxia, and for the neurons these are most sensitive for the hypoxia. Okay, next, how cell injury will occur. So whenever you will see any structure, any injury in the body, first those cells try to adapt themselves. If they are not able to adapt, then this will lead to the injury. The injury will be mostly reversible injury. Okay, until we are keeping on the same stress, it will be reversible, but that stress will be continuous for the longer duration, then it will convert it into irreversible injury, and then cell will die. Okay, so whenever any injury will happen to the cell first try to adapt for that cell. You are not able to hear me. Can you hear me or not? Okay, so whenever any injury will happen to any cell, then first cell try to adapt for that stress, then after stress, that cell, if there will be longer duration of that stress, then cell will go in reversible injury. If that stress passes for too much time, too much severe amount of injury, then it will go in irreversible cell injury, and then ultimately cell will die. Okay, so we will study all these steps one by one. So first step is how reversible cell injury will occur. Okay, so if you know, in reversible cell injury most common cause will be hypoxia. Hypoxia means there is lack of oxygen. So if there is lack of oxygen, then if you know that our electron transport chain which is working in mitochondria, which will not happen, mitochondrial dysfunction. If there is mitochondrial dysfunction, then there will be lack of ATP, or there will be less ATP available. So the first pump to be failed in the reversible cell injury, that will be sodium potassium ATPase pump. Okay, so now sodium potassium ATPase pump will fail. So what happened? Whenever there will be failure of sodium potassium ATPase pump, what this pump will do? This pump is sending sodium outside and potassium inside. Okay, 2 sodium outside, 3 potassium inside. What will happen? This pump is not able to work, so this sodium will start accumulating inside the cell. Whenever this sodium will start accumulating, whenever sodium will start accumulating, there will be increased water going towards the this sodium. So sodium attracts more water. Now this cell try to enlarge, and this first change will be hydropic swelling. Okay, so the first change will be hydropic swelling, or I can say first morphological change during the reversible cell injury will be hydropic swelling. Now this cell will be swelling up, so other organelle like our endoplasmic reticulum and endoplasmic reticulum, our those cell membrane will also swell up. So endoplasmic reticulum, when it will be swelling up, then there will be lack of protein synthesis. When cell membrane cell will swell up, this membrane will be thinner, and then these will form cytoplasmic blebs. Okay, so the first change in the first change in reversible cell injury will be mitochondrial dysfunction. First morphological change will be hydropic swelling. Okay, because of this hydropic swelling, there will be distension of the cell. So cell membrane, some phospholipid will break down, and these phospholipid along with calcium will start depositing in a onion skinning pattern. This is called as myelin figure. Okay, so myelin figure are phospholipid and calcium composition in the reversible cell injury. So for myelin figure, we have only three options. First is myelin figure when they will start appearing in reversible cell injury. Okay, more or increase in amount in irreversible cell injury. So we can say myelin figure is present in both the condition, reversible and irreversible cell injury. Along with that, what is the composition? So composition is phospholipid plus calcium. So they will start accumulating inside the cell, and this is the electron microscopy diagram of myelin figure. So here you can see multiple lamination or concentric lamination of myelin figure. This is called as onion skinning up pattern of myelin figure. Okay, so this is myelin figure. So in irreversible cell injury, first change will be mitochondrial dysfunction. Other than this, there can be, if there is no oxygen, there will be anaerobic glycolysis. So acid will accumulate. When acid will accumulate, there will be less pH. Less pH will lead to chromatin condensation or chromatin degradation. Okay, and next can be, there will be rough endoplasmic reticulum will also, like rough endoplasmic reticulum, if you know, it is having ribosome over this. Okay, so when there is lots of water, these will try to swell up, so these ribosome will be detached, then there will be less decreased protein synthesis. Okay, so majority of cases, we need to remember we have to remember what is the hydropic swelling, how it will come. Okay, and what is the main first change, that is mitochondrial dysfunction. First morphological change will be hydropic swelling. Okay, and why hydropic swelling occurring? Because of sodium potassium ATPase failure. Okay, so and the last question about reversible cell injuries, myelin figure. So myelin figures start appearing in reversible cell injury, continue to accumulate in irreversible cell injury. Composition will be phospholipid plus calcium, and there will be this appearance, onion skinning appearance of myelin figure. Okay, so this is all question about the irreversible cell injury. If this hypoxia will persist for longer duration, then cell will go in irreversible cell injury. So for irreversible cell injury, what you have to remember? So if you know, in irreversible cell injury, there will be lots of damage to the cell membrane. If cell membrane will damage more, then lots of calcium will come inside the cell. Because of this calcium, there will be two types of changes. First, this calcium will go and activate all the enzymes in the cytoplasm, okay, or inside the cell. So activation of all enzymes, okay, will lead to degradation of cell more. Okay, and other will be, it will go to mitochondria and start depositing in the mitochondria. If calcium will start depositing, these deposits are called as amorphous densities. Okay, amorphous densities or flocculent densities. Okay, flocculent densities. So these are the feature we will see in irreversible cell injury. So what we will see in irreversible cell injury? First, more cell damage, more cell membrane damage leads to more calcium to come inside. More calcium will come and it will start activating all the enzymes present inside the cell, like phospholipase, our proteinase, and for other nuclease. Okay, then this calcium will go to mitochondria and deposited in the form of amorphous density or flocculent densities. Okay, other than this, we will have some nuclear changes. Okay, if you know nuclear changes, first nuclear, this is the cell, first nuclear try to condense. Okay, after condensation, it will try to degrade in fragmentation, and it can dissolve. Okay, so this is pycnosis, karyorrhexis, and karyolysis. So in these three forms, nucleus will disappear from the irreversible cell injury cell. Okay, so this is irreversible cell injury. So now if this stress persists for longer duration, then cell will die. So cell death is divided into many types. Okay, so we will start first with the necrosis. Okay, necrosis means cell murder. If you know in locally we are saying cell murder. Okay, so what is necrosis? So for necrosis you need to remember few things. First, this is always associated with inflammation. So whenever we see any inflammation, after inflammation any cell death it will occur, that is necrosis. Second, here cytoplasm will be eosinophilic. Okay, so whenever we are doing any that histopathological changes, then eosinophilic, amorphous, and inflammation. These three will be the characteristic for necrosis. So it is associated with the inflammation. Then there are few types of necrosis. First one is coagulative necrosis. So if you know what is coagulation, so coagulative necrosis is the most common type. Okay, most common type of necrosis mostly occurs in the solid organs. Whatever solid organs we are having in body, there will be occurring of coagulative necrosis, except brain and pancreas. Okay, so in brain and pancreas we will not see the coagulative necrosis. Other than this, every solid organ will have coagulative necrosis. Okay, so here this is the diagram for coagulative necrosis. Okay, if we will do a histopath for coagulative necrosis, we will find a typical pattern of raw tombstone appearance. Okay, other than this raw tombstone appearance, we will also find ghost cell. Okay, so if they will ask you in coagulative necrosis, what will be the histopathological changes? For this, you have to remember the cell architecture or the outline will be preserved or will be normal. Only the inside structures are not be distinguishable. So if we can only make the outline, we cannot draw anything inside, then this will be raw tombstone appearance in coagulative necrosis. Other than this, one derma condition, that is pemphigus vulgaris, we will also see raw tombstone appearance. Okay. Next is liquefactive necrosis. So here in coagulative necrosis, what will be the mechanism? Coagulation of proteins. Okay. For the liquefactive necrosis, okay. So here tissue architecture will also loss. Okay. So if tissue architecture will loss, everything will be converted into small liquids. Okay. So here you can see this is the liquefactive necrosis in the brain. Okay. So this is the liquefactive necrosis in brain. So whatever structure like pancreas and brain, both will show liquefactive necrosis. Liquefactive necrosis is also called as colliquative necrosis. Okay, so the other name for liquefactive is colliquative necrosis. Here tissue architecture will be lost. All tissue will be digested by the lysosomal enzyme, which will be the mechanism, and pancreas and brain will show us liquefactive necrosis. Okay, next is caseous necrosis. Okay, for the caseous necrosis, you need to remember this is the combination. Okay, here coagulative plus liquefactive, both type of necrosis will occur. And if you know caseous means cheese, so cheese kind of appearance we will see. This is here this we will see in TB, like tuberculosis, fungal infections. All of these condition will show us caseous necrosis. So here you can see this curdy white or cheesy appearance. This is our caseous necrosis. Okay, this is the condition in TB or any fungal infection. Okay, next is fat necrosis. Okay, so for the fat necrosis, you need to remember that fat necrosis occur only those areas where we have more fat, like in the breast, in omentum. Okay, so how in breast it will appear? So suppose somebody has got trauma. After trauma, fat will break down into fatty acid. This fatty acid along with calcium start depositing into the same tissues. Okay, so this will show us some milky white appearance in deposit, that is breast trauma leads to fat deposition. Okay, breast trauma leads to fat deposition. Okay, remember for a momentum, if you know pancreas, pancreas. So whenever somebody is having pancreas, there will be leakage of pancreatic enzymes. So pancreatic lipase will come, it will become fat into fatty acid. These fatty acid will take calcium and start depositing into the omentum. This will lead to fatty necrosis. Okay, so here you can see this is our fatty necrosis. You can see these small spots. So here this is all our fatty necrosis. Fatty acid plus calcium deposited here. Okay, it can be due to any trauma or it can be due to pancreatitis. Okay, so for there are two questions. What kind of necrosis you will see in pancreas, or what kind of necrosis you will see in peripancreatic tissues? Okay, so for the pancreas we have to answer liquefactive necrosis. For peripancreatic area or peripancreatic tissue, because we have here omentum, so we have to answer fat necrosis. Okay, so these two are different question you have to answer. Next is fibrinoid necrosis. Okay, so fibrinoid necrosis is mainly due to immune complex deposition. So wherever we have immune complex deposition, we will have fibrinoid necrosis, mostly seen in blood vessel in the condition of polyarthritis, nodosa, rheumatic heart disease in SLE. All of these conditions are having lots of antibodies. They will form the antigen antibody complexes and they will start depositing inside the blood vessel. So they will have fibrinoid necrosis. So here you can see this is our fibrinoid. Okay, this is the lumen of blood vessel. You can see here. So this is the lumen of our blood vessel, and this is the layer of blood vessel. And here you can see this pinkish material. This is our fibrinoid necrosis. Okay, so this is necrosis. Next is gangrene. Okay, so for the gangrene, you have to remember that gangrene is of two types. Okay, dry gangrene and wet gangrene. Okay, in dry gangrene, we have mainly the coagulative necrosis. In wet gangrene, we have mainly the liquefactive necrosis. Okay, and other than this, you have to remember one extra type that is Jenker's degeneration. Okay, for the Jenker's degeneration, you need to remember that this is a special type of coagulative necrosis. Okay, which will mainly seen in the typhoid fever condition. Okay, and the muscles involved here are rectus abdominis and diaphragm muscles. Okay, so these are the separate questions for our Jenker's degeneration. Okay, so Jenker's diverticulum is the different thing. Jenker's degeneration is a type of coagulative necrosis seen in typhoid fever and rheumatic heart disease in rectus abdominis muscle and diaphragm muscle. Okay, so these are all types of necrosis. Once again, we will see all the types of necrosis. So they can ask you to mention the area. Okay, so first one is here you can see this cheesy area. This is our vitreous necrosis. Okay, second one here you can see these white spots. This is our fat necrosis. This thready area, this is our fibrinoid necrosis because this is the lumen of blood vessel. Here you can see the whole area is digested by the lysosomal enzyme. This is liquefactive necrosis or colliquative necrosis. And the last one, this area is our coagulative necrosis. Okay, so these are our different types of necrosis. Next, there is another type of cell death, that is apoptosis. Okay, so for apoptosis, what uh, what is the definition of apoptosis? So for apoptosis, you have to remember this is in simple we can say suicide. So now cell is activating its own machinery to die. Okay, so this is cell simply a cell suicide. What will be the definition? These are caspase dependent programmed cell death. Okay, so whenever they will write you any definition for apoptosis, that is caspase dependent program cell death, means cell is dying by the help of caspase. Caspase are the enzyme. Okay, what will be the hallmark for apoptosis? So what will be the hallmark for apoptosis? Can anybody say? So hallmark for apoptosis will be nuclear chromatin condensation. Whole nuclear chromatin will be condensing. Okay, so now this apoptosis we will be seeing in physiological conditions, also in pathological condition also. So in physiology, if you know, in embryogenesis we have lots of cells. Those cells are dying by the help of apoptosis. Okay, for the pathological, you have to remember two bodies. One is councilment bodies, okay, and other one is civet bodies. Okay, councilment bodies we are seeing in hepatitis C virus, where we have nuclear chromatin condensation. Civet bodies are in the lichen planus. Okay, so these are the main two examples. Other than this, we have lots of examples, but these two are by the name. So we have to remember councilment bodies and civet bodies. In the physiologically, this will be in embryogenesis. Okay, other than this, apoptosis is a active mechanism. Okay, active mechanism, this is a active mechanism because this will be done by the help of ATP uses. Okay, I will share Abbas. Okay, next is what type of caspases we have. So we have two type of caspases. One are the initiator, which will start doing this apoptosis. Other one will be the executors, which will further progress the apoptosis. Okay, so initiator are divided into two, intrinsic and extrinsic, because apoptosis is happening by the two pathways. One is the stimulation by the inside of the cell, so that is intrinsic. Stimulation by the external factor, that will be the extrinsic pathway of apoptosis. In intrinsic, we have caspase 9, okay, and for the extrinsic we have caspase 8 and 10. Okay, so in initiator we have 8, 9 and 10 caspases. 8 and 10 are helping in the extrinsic pathway, 9 will be helping in the intrinsic pathway. Okay, the extrinsic pathway is also known as death receptor pathway, or CD95 ligand pathway, or fast receptor or fast ligand pathway, because all of these molecules we will be using in the extrinsic pathway. For the execution, we have only three, that is 3, 6 and 7. Out of these, 3 is the most important caspase. Okay, so for caspase we have two types: initiator, executor. Initiator are divided into which are used in the intrinsic pathway, that is intrinsic caspases, and extrinsic caspases. In intrinsic we have caspase 9. For extrinsic we have caspase 8 and 10. Okay, for the intrinsic pathway you have to remember, like whenever any cell is getting stress from the outside, okay, this is stress will lead to damage inside the mitochondria. These mitochondria will sense this stress. Those are called as stress sensors. Okay, so what are the stress sensor for our body? That is Bim, Bed, Noxa, Puma, and Bimbid bed, Noxa, and Puma. Okay, these are our stress sensors. So whenever any cell, suppose I am giving this cell a radiotherapy, this cell is sensing all of these stress by the stress sensor. So they will get activated. Whenever they will get activated, there will be more expression of pro-apoptotic and less expression of anti-apoptotic genes, and cell will die. So what are the pro-apoptotic uh, factors? So that is P53, that will be BAX, and BCL-XL. These BCL-XS, these all are our pro-apoptotic factors. And what are the anti-apoptotic? That will be BCL2, MCL1, and BCL-XL. All of these are our anti-apoptotic factors. So how we will define apoptosis? So suppose this is a normal. So how as many pro-apoptotic genes will be activated, same amount will be anti-apoptotic will be activated, and cell is living a normal life. Now some stress will come. Stress sensor has checked that sense. Now they have start increasing expression of pro-apoptotic and decreasing the expression of anti-apoptotic. So now apoptosis will be more and cell will die by the process of apoptosis. Okay, so these are the main thing. Okay, other than this, you have to remember these fast ligand and CD95 are present mainly on the cytotoxic T cell. Okay, so CD8 T cell. These will be present on CD8 T cell. So in apoptosis, we have role of CD8 T lymphocytes or cytotoxic T lymphocyte. Okay. Now, what are the if If you know in intrinsic pathway, we will have role of APAF and Diablo, SMAD, all of those proteins, and they will degrade. So you will study this detail in from your notes, but for question purpose, you need to remember type of caspases and these stress sensors, pro-apoptotic proteins and anti-apoptotic proteins. Okay, now we will come to the marker or diagnosis of apoptosis. Okay, so for the diagnosis of marker of apoptosis, the apoptotic marker is, what is the apoptotic marker? This will be annexin 5. Okay, so annexin 5 will be the apoptotic marker. Okay, what will be the molecular marker? That will be CD95, or I can say FAS. Okay, so these are our apoptotic markers. Then how we will see these apoptotic cell inside the microscope? So for the microscope, you have to remember cell size will decrease. So I can say cell is shrinking. Okay, other than this, there will be more or increase eosinophilic staining. Okay, so there will be increased eosinophilic staining. Along with that, there will be nuclear chromatin condensation, which will be our hallmark feature of apoptosis. So these feature we will see in microscope. Okay, so these are three features. So as cell is getting apoptosized, this will be decrease in cell size, more eosinophilic environment, and nuclear chromatin condensation. Next is tunnel staging. What is tunnel staging? So for tunnel staging, you need not to remember the full form, and you have to just remember it is positive for apoptosis. So you will find this test positive in apoptosis and negative in necrosis. Okay, just you have to remember this. That's it. Okay, next is what will be the in gel electrophoresis. So here you can see this is gel electrophoresis. The first part is our normal DNA, because normal DNA is normal, or it is not having any breaks, so it will be accumulated at the one side. In apoptosis, if you have remember that APAF factor, apoptotic factor, this will degrade our activate internuclease enzyme, which will degrade after every 180 to 200 base pairs. So now we will have multiple fragments of DNA. So this will lead to step ladder pattern of apoptosis. Okay, when we will compare this with necrosis, necrosis is having smearing pattern. Okay, but these patterns are not specific for apoptosis and necrosis, because step ladder we can also find in necrosis, but if they will ask you for which it is more common, then it is more common for apoptosis. So these are non-specific, still we have to know for the question purposes. Okay, so for gel electrophoresis, step ladder pattern we will see more common for apoptosis, less common for necrosis, but in necrosis also we can see this pattern. Next is flow cytometry. Okay, so what we will see in flow cytometry? So in flow cytometry, we are checking the cell which are having more expression of annexin 5. Okay, so here you can see this is dot blot pattern of flow cytometry. Here you can see this side we have AAD. This AAD will go and bind to the living cell DNA. Okay, so we will check the living cell on the one side and the annexin 5 on the other side. Okay, so now we will divide this flow cytometry into the four compartments. So here, whatever the cells are present, they are having more. They are having 7 AAD. Okay, so these are the living cells. In this compartment, you can see they have annexin 5 presentation also, plus 7 AAD, means these are the cells which are in the early phase of apoptosis. But here you can see most of the cells are present, are having only annexin 5. Okay, so these are the cells which are dying, or these are in the late apoptotic phase, or we can say these are apoptotic bodies. Okay, so this is how we can check in flow cytometry. So for flow cytometry, we are using annexin 5. Okay, so this is all about apoptosis. Okay, now we have some special type of cell death, that is necroptosis. So name is only saying this is necrosis plus apoptosis. Okay, so necrosis plus apoptosis. Why? Because this is having present, their inflammation will be present, and these are programmed cell death, but this is without caspase or not caspase dependent. Okay, so these are without caspases. So caspase independent cell death plus inflammation, that is our necroptosis. Okay, so for necroptosis, you have to remember that this will also occur in physiological conditions. Okay, and can also occur in pathological conditions. Okay, so for physiological, you can remember those growth plate damages, everything will be in physiological. For pathological, you can remember fatty liver. So whenever liver in this fat will start depositing in liver, they will have necroptosis. Okay, and other than this, you can remember those reperfusion injuries. Okay, after MI, those reperfusion injuries are also by necroptosis. Okay, and also cytomegalovirus. Okay, this cytomegalovirus cannot be killed by the apoptosis because it is having caspase inhibitor. So it will inhibit caspase, so apoptosis will not work over cytomegalovirus. So this virus can be killed by the process of necroptosis. Okay, for necroptosis, you have to remember the pathway. So the pathway start with the uh, TNF and TNF receptor pathway, or you can say TNF receptor will be involved. They will activate RIP1, RIP2, RIP3, and procaspase procaspase 8. Okay, so they will activate them, and then there will be phosphorylation of myosin like kinase. Okay, so light chain kinase, and they will activate them, and there will be death of these cells. So this will be involved. So if they will ask you what is the process which is programmed cell death, having phosphorylation of MLKL, involvement of TNF receptors, and having intermediate like RIP1, RIP3, and procaspase 8, then the pathway will be necroptosis, and we will see this in a fatty liver condition, reperfusion injury. In physiologically, we can also see this in our growth plate degeneration. Okay, and here cell death is mainly by the increase of the free radical injury, or there will be injury by the free radicals. Next is pyroptosis. So if you know, pyro means fever, optosis means death. So if any cell, program cell death by the fever, or the fever interleukin is interleukin 1, then the cell death will be pyroptosis. So in pyroptosis, you have to remember this will be mainly activated, or this has the involvement of receptor node like receptors. Okay, whenever node like receptors will be activated, there will be for activation of inflammasome. Okay, these inflammasome will lead to activation of caspases. What caspases? 1, 4, 5, and 11. Whenever these will activate, this caspase 1 lead to more production of interleukin 1. So patient will have fever, and other caspases will lead to cell death. Okay, and these condition we are mainly seeing in bacterial inflammation, mostly Shigella and Salmonella conditions. Okay, so whenever somebody is having salmonella infection, the cell death is by the pyroptosis. So here the caspases are involved is 1, 4, 5, and 11. One will lead to the fever, and other lead to the cell death. Okay, then next will be ferroptosis. Okay, so for ferroptosis, ferro means iron and optosis means death. Okay, so whenever this will lead to the death, this will be ferroptosis. The protein, or that enzyme will be involved with GXS4. Okay, so this will be the ferroptosis. There is one more condition, that is anoikis. Okay, so anoikis is also a type of apoptosis. You just simply need to remember loss of internal environment lead to the anoikis. Okay, so this is our these are our types of cell death. Okay, so this is all about cell death. Now next is autophagy. If you know autophagy means self eating, or I can say cell cannibalism. Okay, so this autophagy mostly occur in the condition like senile old age, malnutrition, or cancers. So whenever we have more demand but less intake, then our body will eat its own substance, that is autophagy. For this autophagy, you have to remember Sir Yoshinori Ohsumi, who got in 2016 Nobel Prize. Okay, so if you want, you can remember this. Maybe they can ask you. Okay, so next is the types of autophagy. For autophagy, we have four types: macroautophagy, microautophagy, chaperone-mediated autophagy, and mitoautophagy. Macroautophagy means whatever the cell is, whatever organelle are present inside the cell, if they get damaged, cell can eat them by their own. Okay, so what happens? Suppose cell is having this mitochondria, which is of no use. These ribosomes are of no use. So cells start forming membrane around this by the ULK1, backlin 1, LC3, and they cover them and form autophagosome. Okay. Now cell will attach lysosome to this, and this lysosome will form autophagolysosome, and they will degrade and get energy from this. This is macroautophagy. So for macroautophagy, you have to remember ULK1, backlin 1, and LC3. These are helping in the formation of autophagosome. For microautophagy, the main process will be endocytosis. So suppose this is this cell, it wants to eat anything outside the cell, some substance, it will form these pseudopodia, take it inside, then attach lysosome and degrade them and getting energy. That is microautophagy. For chaperone mediated autophagy, if you know, these chaperone are required for the proper protein foldings. Okay, so if somebody is having improper protein folding or bad proteins, then these protein by the help of LAMP2A on the lysosome enter into the lysosome and getting degraded and releasing energy. This is our chaperone mediated autophagy. For mitophagy, this is particularly for mitochondria. So if cell has any damaged mitochondria, this will tag with them pink and Parkin proteins. These proteins help cell to identify that these are our base mitochondria, and cell eating them and degrading and getting energy. That is mitoautophagy. So these are all our types of autophagy. Okay. Next is, what is the marker for autophagy? So marker for autophagy is LC3 or light chain 3. Okay, so the marker is light chain 3. What will be the genes? So all genes will be ATG. The ATG1 will be the main gene, and we have two genes from which if any defect will occur in these, then patient will have more risk. So ATG5 will have, if any defect with ATG5, patient will have increased risk of TB. Okay, then ATG16L, if any defect will lead to inflammatory bowel disease. So these two you have to remember, because whenever we will be studying TB, in TB we will be studying the risk factor. So the risk factor genetic can be the ATG5 mutation. Okay, for IBD also they can have ATG16L mutation, and they will have increased risk of developing inflammatory bowel disease. Okay, and along with that, if you know that vitamin D deficiency is also a causative factor for TB, so these you have to remember. So this is all about cell injury. Now we will come to the cellular adaptation. Okay, so if you know, cell will adapt only by these five mechanisms. So first mechanism is hypertrophy. Okay, other one is hyperplasia. Next is atrophy, metaplasia, and dysplasia. Okay, so hypertrophy means trophism. If you know, trophism means increase in cell size. Okay, hyperplasia means increase in number. Atrophy means decreasing in size, decreasing in cell number. Okay, metaplasia means one type of cell is converted into same other type of cells. Okay, so suppose epithelium we are taking as example, this epithelium will be converted into different type of epithelium, that will be metaplasia. What is dysplasia? So dysplasia means something bad or some abnormal tissue will form, that is dysplasia. So some abnormal structure will form, that is dysplasia. So what are the examples of hypertrophy? How hypertrophy will occur? So for hypertrophy, we have some transcription factors. So whenever any stress will come, it will start activating our cell. When cell has to form more protein, it will activate our transcription factor. Those transcription factors are GATA4, NAFT, and MER2. These three you have to remember anyhow, because they will ask you what are the transcription factor for hypertrophy except. Okay, so whenever we have any three things together, they will ask you as a except question. So these three will be the transcription factor for the hypertrophy. Now, what are the examples of hypertrophy? So, what can be the examples of hypertrophy? So if you know, the universal will be gravid uterus or the pregnant uterus. So if some pregnancy will occur, then uterus will have hypertrophy, but it can also show hyperplasia, but here we are using only for hypertrophy. Okay, other than this, breast. Okay, breast during the lactation we can also have hypertrophy. Yes, muscle hypertrophy we can see. So muscle hypertrophy, where you will see, so muscle hypertrophy in the skeletal muscle. So if you know a simple concept, that those cells which are able to divide, okay, they can mostly show the hyperplasia. Which cannot divide, they will mostly show the hypertrophy. Okay, so here muscle hypertrophy, or you can also see in any bodybuilder athlete we will have muscle hypertrophy, or any uh, proximal to any obstruction. Okay, proximal to any obstruction means, suppose somebody is having renal stone. Okay, somebody is having renal stone in the urethral opening. Okay, here if somebody is having urethral opening and we have renal stone, so because of this obstruction, urine is not going out, so this bladder will start hypertrophied. Okay, so this will be the example. Other than this, left ventricular hypertrophy because of aortic stenosis, chronic hypertension. Okay, for the breast, you have to remember, for breast we have different conditions, like if breast in the lactation we will have more hypertrophy, but if you will ask in puberty and pregnancy, then in puberty and pregnancy it will show more hyperplasia, but it can also show hypertrophy. So for breast, both in puberty, pregnancy, but more common is hyperplasia, same as uterus. Like is in uterus during pregnancy it will show more hypertrophy than hyperplasia, but it can show both. So if they will ask you to mark one, then you will choose hypertrophy. If the option is saying hypertrophy plus hyperplasia, then the answer will be that. Okay, so the more common in uterus will be hypertrophy. Breast in puberty and pregnancy will be more common, will be the hyperplasia. In lactation will be hypertrophy. Same, breast during menopause or after menopause can show atrophy also. Okay, so you have to remember, breast can show atrophy also. Okay, now for the hyperplasia, you have to remember, for hyperplasia, mostly those organs which are having hormone dependent, like endometrial hyperplasia. Okay, so endometrial hyperplasia we can see, prostatic hyperplasia. What else we can see? So endometrial hyperplasia, when female is having more estrogen, more hyperplasia of endometrium. When male is having more testosterone, this testosterone will get converted into dihydroxytestosterone and lead to the more hyperplasia of prostatic gland. Okay, so these are all will be the hyperplasia. Okay, what are the examples of atrophy? For the atrophy, you need to remember that there will be decrease in cell size, cell number both. Okay, the mechanism main here will be ubiquitin proteasome pathway. Okay, so ubiquitin proteasome pathway, if you know, any protein which want to degrade, we are degrading by this system. So this will be hyperactive in atrophy. So mostly both proteins are getting degraded. So cell will not grow. So decrease size, cell cannot divide. So decrease in number. So where we can see this our atrophy, first is disuse atrophy, means if we are not using any muscle or any part of body, that will go disuse atrophy. Then other can be pressure atrophy. Okay, so if somebody's liver is having some mass or some adenoma, it will be compressing other part of the liver, so other cells will not grow, so this will have pressure atrophy. Other than this, or for this same example will be that cast, after fracture somebody is having cast applying over those fracture too. So for that also they will have pressure atrophy also and disuse atrophy also. Then there can be ischemic atrophy, like if we will obstruct any blood vessel, this will also lead to atrophy. There will be any neuronal injury, after neuronal injury there will be neuronal atrophy or denervation atrophy. And endocrine atrophy, endocrine atrophy we will mainly see in breast, like if somebody is having less estrogen, breast will not develop, so or breast will get atrophied, so that will be endocrine atrophy. So these are the main examples of atrophy. What is the metaplasia? So one kind of tissue will be converted into other kind of tissue. So epithelium gets converted into epithelium. Here are most famous example for this, or most common type will be column. Columnar will be converted into squamous. Okay, this we will see in chronic smoker or smoking, and also vitamin A toxicity or vitamin A deficiency. Okay, so these two, this is the most common type of metaplasia. Other than this, squamous is if getting converted into columnar with goblet cell, then that is the example for Barrett esophagus. Okay, so in Barrett esophagus, somebody is having chronic GERD. Continued reflux is occurring into the esophagus. Because of that reflux, squamous cell are getting converted into columnar type, especially the intestinal type. So this is called as Barrett esophagus or intestinal metaplasia. This is the risk factor for adenocarcinoma of esophagus, means this is a precancerous condition. But these metaplasia are 100% reversible. Okay, whenever we are removing our stress, they will be reversible 100%. Plus they have mechanism. That mechanism is their stem cell will be converted into different types, or there will be reprogramming or reprogramming for these stem cells. Okay, so stem cells, if we reprogram, they will try to form some other, that is metaplasia. Okay, other than this, this is for the epithelium. If you have any example for mesenchymal to mesenchymal, the answer will be myositis ossificans, means somebody is getting any injury into the muscle, and during that repair, that muscle will have some kind of bone deposition, that is myositis ossificans. Whenever we will see that muscle, whenever we will see in myositis ossificans, we will see the outer part is uh, quite dense in the X-ray, inner part will be hollow. This is for myositis ossificans. Okay, for one cancer, this will be opposite, that inner will be more dense, outer will be less. So this will be in bone cancers. Okay, so we have to remember that if a myositis ossificans is present, means this is the metaplasia of muscle to bone. So or mesenchymal metaplasia. Okay, for dysplasia, we will be studying this under the neoplasia. For dysplasia, you have to remember this is partially, okay, partially reversible. Okay, and it has few features which will be similar to anaplasia, except one feature, that is basement membrane is intact here. Okay, other features like polarity, so loss of polarity it will show. It will also show hyperchromasia, means more staining to the new cell. Okay, and also it will show nucleus cytoplasmic dysynchrony, means the cytoplasm and nuclear ratio will be more. So these all will be the feature of dysplasia. We will be studying in detail in neoplasia chapter. Okay, so these are our all cellular adaptation. Okay, so for breast, if you know, for breast you have hypertrophy in lactation, hyperplasia in pregnancy puberty, atrophy in uh, endocrinal atrophy. Okay, so breast can show and both all. Okay, breast can show all. So this is all about our cell injury chapter. Next will be the inflammation. So what is the inflammation? What is inflammation? So inflammation anywhere, if we will write behind any word or suffix, that is itis. So suppose vasculitis, pericarditis, pleuritis, all of those are inflammation. Okay. So for inflammation, you have some cardinal features. Okay. What are the cardinal signs of inflammation? That is rubor, calor, dollar, tumor, and the last one is functionalism. Okay, so if anywhere inflammation is going on, this will show redness, that is rubor. It will show increase in local temperature, that is calor. Increase in pain, that is dollar. More swelling, that is tumor. And the functionalism is loss of function. All above four will be was given by the Celsus. Last one was given by Virchow Rudolph. Okay, so Rudolph Virchow has given the last one. Okay, next is what is the acute inflammation? So if you know acute and chronic inflammation differentiation, if you I will ask, what will be the having quicker onset? Acute. Delayed onset? Chronic. Okay. So here delayed, this will be the acute onset or early onset. What are the cells prominent in acute? The cells will be neutrophil. Here it will be macrophage, monocyte, and lymphocyte. All of that will be in chronic inflammation. Other than this, what will be other difference for acute and chronic? So, what will be the short term? Short term will be acute, long term will be chronic. Okay, so these are the major difference between acute and chronic. So, what is acute inflammation? So acute inflammation has two events. One is vascular event, other one is cellular event. Vascular event in the relation of blood vessel, cellular in the relation of WBCs. Okay. So blood vessels, there are only four events. One is vasoconstriction, then vasodilation, then increased vascular permeability, and last one will be stasis. Okay, so as soon as injury will occur, first event and transient event will be our vasoconstriction. After vasoconstriction, we will be having vasodilation. Because of vasodilation, we will be having rubor and calor. Okay, so those two will be by the our vasodilation. Then next will be increased vascular permeability, which is the hallmark feature for our acute inflammation, and because of that we are having tumor feature. Okay, then after so much vasodilation, almost all, we will have more vascular permeability increase, more blood will be low, more plasma will be out, so we will have stasis in the end. So these are our vascular event, and this vascular permeability more in the post venules. Okay, so after post venule capillaries we will be having more or maximum increase in vascular permeability. About these cellular events, we will be reading in relation to WBC. So first one will be margination, when our cells will come to the margin. Then they will start rolling. Okay, rolling is also called beak adhesion. Okay, so they will be weakly adhere on the endothelium. Then there will be firm adhesion or adhesion. Next will be transmigration. Okay, after transmigration, what step we will have? After transmigration, we will be having our chemotaxis. Okay, after chemotaxis there will be opsonization, and after opsonization we will be having our phagocytosis. Okay, so these are the steps we will see under the cellular events in acute inflammation. So before going to cellular events, we will come to the how we can increase our vascular permeability. Okay, so to increase vascular permeability, we have only these five mechanisms. First one and the most common will be our endothelial gap. Okay, so endothelial gap means, if you know, our endotheliums are present like this. If I want to send something out of the blood vessel, I need to make space in between. Okay, so these endothelial cell gap, how they can form? These endothelial cells are having some myocyte, or I can say they have some myofibrils. Okay, these myofibrils will contract. If they will contract, we will have gap in between. So this will be the endothelial gap. Next can be these ends will contract or they can retract from one another. So if they will retract, these two endothelial cells will go apart, and we will have more endothelial gap. Okay, so the first and most common mechanism will be endothelial cell gap. The immediator responsible are histamine and serotonin. Okay, and this is, if you know, this is the immediate response, and the transient, as soon as injury will occur, first step will be immediate, transient, that is endothelial cell gap, by the which will cause the increased vascular permeability. Okay, so the histamine and serotonin will come, and they will ask cell to either retract or contract, and lead to the immediate transient response for vascular, increasing vascular permeability. Okay, next is direct injury. So if any substance, suppose any toxin will come inside the blood vessel, it will go and directly damage our endothelial cell and lead to the increased vascular permeability. Okay, this in Robinson they have divided into two: severe, it can be severe, or it can be in milder form. Okay, so the milder form means the occurrence will be slow, so it is a delayed response. Okay, so this is a delayed response and a prolonged response. So anything comes late stays for longer duration. So delayed and prolonged response will be in the milder direct injury. Severe means suddenly so many things are happening, so many cells are getting damaged. So did this will be immediate response. Okay, so suddenly so much damage to the endothelial cells, so immediate response. Plus this is a sustained. This will also be more damaging. Okay, this we will see mainly in the condition of sepsis. So direct cell endothelial cell injury will be severe and mild. Mild will be delayed and prolonged duration. Severe will be immediate and sustained and mainly seen in the sepsis. Okay. Next is transcytosis. Okay. For transcytosis, you have to remember VB organelle. This VB organelle means we have these endothelial cells. In these endothelial cells, we are keeping our vesiculovascular organelle, and they are helping us to increasing more vascular permeability. Okay, for angiogenesis you will have vascular endothelial derived growth factor, and they will help in the formation of more immature blood vessel. When any blood vessel will be forming, this is immature, they are not having continuous endothelial lining. If no continuous endothelial lining, then there will be more vascular permeability and more leakage of fluid outside, so more vascular permeability. Other than this, leukocyte can also damage our endothelial cells, so lead to leukocyte mediated cell injury will also lead to increased vascular permeability. So these are the five mechanisms by which we can increase, or in inflammation there is increase in vascular permeability. Okay, next events are our cellular events. So for cellular events, first one is margination. Okay, so for margination you have to remember, suppose this is our blood vessel. Okay, so in blood vessel in the center we are having all our RBCs. After this we are having WBCs. Okay, this is our laminar flow. Outside all of those, the plasma fluid will be in the this, and platelets are also distributed along the blood vessel. Okay, so whenever we have any injury, first plasma will go out because of increase in vascular permeability. So plasma will go out. Now what are the next cell? These are the WBC. They will come to the margin. So this is our margination. Now these WBC start rolling over these endothelial cells. So they will roll over the endothelial cells by the help of our molecule, that is selectins. Okay, selectins are of three types: E selectin, P selectin, L selectin. This selectin is also known as CD62. So these selectins are E, P, and L. Okay, these E, P, and L selectins, these E selectins are mainly present on the endothelial cells. P-selectin endothelial cells, they will also come by the histamine and serotonin, and also present on the platelet. These L-selectins are present only on the leukocytes or our neutrophils. Okay, so these are our selectins. Okay, so if you can see here one cell, okay, this cell, this is our neutrophil. Here you can see this is having a one factor, that is Cialyl-Lewis X. Okay, so this Cialyl-Lewis X will bind to our P selectin and E selectins. Okay, so when they will bind to P and E selectin, this cell will start rolling over these endothelial cells, because we want to take this cell outside. So this cell is moving so fast. So first we want to slow down the speed. We will be slowing down the speed by the help of rolling. Okay, after rolling, okay, so in the rolling, they will help. This rolling will be happen by E selectin, P selectin with Cialyl Lewis X factor. Okay, they will bind to Cialyl Lewis X. Other than this L selectin will also bind to our will also bind to our factors on the endothelial cells. So this L selectin will also bind to glycam 1, or this is medcam 1, or they can also bind to CD34, which is the marker of our endothelial cell. Okay, so these selectins will help the cell in the rolling or weak adhesion. After this cell will get firmly adhere to the endothelial cell by the help of integrins. Okay, so for integrins, you have to remember that integrins are of two type: beta 1 beta 2. Okay, these integrins will help the cell to bind adherently to these endothelial cells. Okay, so these endothelial cells will have a these WBCs will have integrin beta 1 and beta 2. These integrin will bind to this beta 1 will bind to VCAM1, and this beta 2 will bind to ICAM1. Okay, so they will bind to the endothelial cells VCAM1 and ICAM1. This VCAM1 is also known as CD105. This ICAM is also known as CD54. Okay, so these are the CD marker for them. For beta 1, you have to remember other name. This is also CD1118. Okay, other than this, this is also known as LFA1. Okay, this is LFA1, or this is also known as MAC1. Okay, so these are our ICAMs. Okay, not beta. They will also bind to these. So this is ICAM1 molecule. These they will bind to ICAM1 molecule. Okay, so these are our beta 1. Next is beta 2. Beta 2 is also known as VLA4, VLA4, alpha 2, alpha 4, beta 7, and these will bind to our these VCAM molecules. Okay, so these are our integrin. So for simply, you have to remember that integrin are beta 1, beta 2. Beta 1 is CD1118 bind to VCAM1, and this beta 2 CD49 bind to our ICAM1. Okay, so these are our addition. Now this cell is strongly adhered to the endothelial cell by the help of matrix metalloproteinase. Okay, plus PCAM1 or this CD31. This will be transmigrating or going outside this blood vessel. This is called as transmigration. Now this cell came into the extracellular environment or extravascular area. Now this cell has to move towards the microorganism. So whatever microorganism is sending signal, unidirectional signal to attract that cell, this phagocytic cell, those are called as chemotaxis or chemoattractants. Okay, after chemoattractants, this cell is these microorganism are bind with any opsonin proteins. This is opsonization, and then our WBCs will engulf them. That is phagocytosis. Okay, so for transmigration, you have to remember PCAM1 and CD31. Okay. For chemotaxis, we have two exogenous factors and endogenous factor. For exogenous, you have to simply remember the bacterial products, whatever the bacterial lectin or mannose protein. For endo, you have to remember C5A, C3A. All of these are our chemotactic factors. Okay. And you have to remember leukotriene B4 and this interleukin 8. Okay, all of these are our chemo attractant. For opsonization, you have to remember opsonization. Best opsonin will be IgG antibody. If they will ask you best complement, then this will be C3b. So these are our opsonin proteins. Then we have phagocytosis. This phagocytosis has three steps. First is recognition and attachment. So first, these phagocytic cell will recognize which cell they want to eat. Then they will attach to them, then they will engulf them by the process of endocytosis, and they will do the killing. So for the killing, we have to remember the types. Okay, so this killing by the two method, one will be the oxygen dependent, other will be oxygen independent. For oxygen dependent, you have to remember few enzymes. First one is NADPH oxidase enzyme. You have to remember this enzyme. Whenever oxygen want to enter any lysosome, this is present in the lysosomal cell membrane and cytoplasm. So this will convert all of those oxygen to superoxide. And then by the help of superoxide dismutase, those superoxide will be converted to hydrogen peroxide. Then by the help of myeloperoxidase, this hydrogen peroxide will be by the myeloperoxidase plus chloride, they will be converted to hypochlorous acid, and that bacteria will be killed. For oxygen dependent, for oxygen independent, you have to remember mainly these lysozymes, lactoferrins, mannose binding proteins. All of those are helping in oxygen independent. For oxygen dependent, we have one more pathway. That pathway is for whenever arginine getting converted into nitric oxide. Okay, so this nitric oxide by the help of those by with the superoxide, they will convert into peroxynitrate and they will also help us in the killing. Okay, so in the killing you have to remember the main NADPH oxidase enzyme. So any defect with this enzyme will lead to the defect in the phagocytosis. So here these are our all the steps of phagocytosis. Okay, now we will come to the disorder related to our inflammation. Okay, so first disorder is our leukocyte addition defects. Okay, so the leukocyte addition defects are of three types. Okay, so here the main problem with the addition. Okay, so what will be the problem with the addition? So in the addition, if you remember that we have one weak addition and one is strong addition. Okay, so for the weak addition you have to remember that in the weak addition we have Cialin-Lewis factor, Cialin-Lewis Cialin-Lewis X factor. Okay, so if any defect with this Cialin-Lewis factor, then we will have lead 2. So lead 2 or leukocyte addition defect is the defect in our rolling process. So in the rolling, if any defect with this Cialin-Lewis X will lead to lead 2, and for lead 2 they will give you a simple hint that patient's blood group is Bombay blood group. Okay, so what is Bombay blood group? These patient will don't have any antigen. Okay, so they don't have any H antigen, they don't have any A antigen, they don't have any B antigen, but they have antibody for H antigen, A antigen, and B antigen. So they cannot receive blood from the any. They just need our Bombay. They just need the Bombay blood group to be transfused. Okay, so this Bombay blood group is NTH, NTA, NTB, and the hint will be here Bombay blood group, and the defect will be Cialis-Lewis X factor. Okay, for lead 1, there will be defect in integrin beta 2, that's CD11-18 problem. Okay, so if any defect with integrin beta 2, this will lead to lead 1. Okay, so here they will give you a hint of that there will patient will have delayed umbilical cord separation. So mother will say that my child's umbilical cord separated very delayed. Okay, so then the hint will be here will be delayed umbilical cord separation. The answer will be lead 1. For the for lead 3, the defect will be from T3 gene defect. This gene is producing the integrin beta 2. Okay, so the defect here. So all of these lead are, if you know, these all are autosomal recessive conditions. Okay, so means they will have symptoms in early age. Whenever we have any disease which is having autosomal recessive inheritance, they are appearing in early age groups. Plus, they are not present in all generation. Okay, there will be generation skipping present. Other than this, in all of these conditions, patient will have recurrent infection. So mother will always say child is having sometimes otitis media, sometimes nasal infection, sometimes throat infection. Okay, and other than this, we will also have these hints. Then the diagnosis will be defected in addition. So lead 1 defect in integrin beta 2, lead 2 defect in Cialin-Lewis X factor, lead 3 defect in firm T3 gene. For lead 1, they will give you delayed umbilical cord separation. For lead 2, they will give you Bombay blood group history. For lead 3, they have features similar to lead 1, plus there will be platelet dysfunction or there will be bleeding present. Then the diagnosis will be lead 3. So these are the defect related to addition. Okay. Next defect is in the opsonization. Okay, so for opsonization, I have told you we have IgG and C3b. Okay, so if somebody is having any problem with the IgG, so either they can produce less IgG, less antibodies, or they can have absent antibodies. Then they will have defect in opsonization because the C3b is normal, so we will only saying defect is opsonization, not in absent opsonization. Okay. Other than this, the condition is called as Bruton's hypogammaglobulinemia. So what is Bruton? For Bruton, you have to remember this is X-linked recessive disorder, means more common in boys. Okay. So since recessive, so early age boys. Okay. Next, they will have a problem with B cells because antibodies are produced by the B cell. Next, there is the defect in the BTK gene, Bruton tyrosine kinase gene defect. So what happened here? So if I will draw one bone, this is our bone marrow producing B cell. This is producing pre and pro B cell or the immature B cells. Okay, this immature B cell require BTK gene or BTK protein to convert it into mature B cells. Then these B cells will be converted into activated B cells. Those are our plasma cells. Now these plasma cells start producing antibodies. Okay. So if any defect in BTK, then there is lack of mature B cell, lack of plasma cells, lack of antibodies or absent antibodies. Okay, so this is our Bruton hypo and A gamma globulinemia. So for this, they will say that patient is having recurrent infection of eco virus, poliovirus, or herpes virus. Any viral infection patient is having continuously. Okay, so this is Bruton's gamma A gamma globulinemia. So X-linked recessive disorder, so more common in boys. B cell defect and BTK gene defect. Okay, so we will have more pre and pro or immature B cell, but lack of mature B cell. So that's why patient will have lack of antibodies. Okay, so this is defect in opsonization. Okay, next is defect in phagocytosis. Okay, so phagocytosis defect means that enzyme is having problems. So now we will have two problems. Phagocytosis, we will have lysosome. So either those lysosome have some problem, or their that enzyme NADPH oxidate that is having some problem, then patient will have defect in phagocytosis. So Chediak-Higashi syndrome. Okay, so Chediak-Higashi syndrome is the problem with the list gene defect. Okay, list gene defect is lysosome trafficking gene. This gene is required to activate all the lysosomes in the body. So in Chediak-Higashi, we will not have only symptoms of defect in inflammation, we will have other defect also, because these lysozymes are also required for the melanocyte to release melanin. So if somebody is having all the lysosome problem, then there is no release of melanin, so patient will have albinism. So here you can see photo of a baby, okay, a boy who is having very silvery hair and very shiny skin. Okay, so it means there is lack of melanin. Uh, this is also our disorder of inflammation. Okay, other than this, patient will also have recurrent infections because of phagocytosis defect. This neutrophil will have more granules. So here you can see neutrophils are having more granules. Okay, other than this, we will have more uh, patient will have uh, neurological disorders. Okay, and patient will also have recurrent infections. All of these symptoms we will see in this Chediak-Higashi syndrome. So for Chediak-Higashi syndrome, you have to remember that for Chediak-Higashi syndrome, patient will have albinism because of defect in lysosomal genes, lysosomal trafficking genes. Other than this, patient will have more neurological symptoms, albinisms, and patient will also have delayed milestones if it is a baby, and granules inside the neutrophil, because lysosomes are not able to bind with those engulfed material, so they will have more defect in they will have accumulation of those granules inside the lysosomes. Okay, so these are Chediak-Higashi syndrome. Okay, so in Chediak-Higashi syndrome, I hope you understood this is lysosomal trafficking gene. So wherever we have required lysosome, though if those are not working, then we will have disorder of Chediak-Higashi syndrome. Okay, so next disorder is our chronic granulomatous disease or CGD disease. Okay, so for CGD, what will be our answer? So CGD is the defect in the NADPH oxidase enzyme. Okay, for Chediak-Higashi, if you know that if platelet will also have lysosome, so hemorrhage will also occur. Okay, so these are few features of Chediak-Higashi. Okay, for chronic granulomatous disease, you have to remember that this is defect in NADPH oxidase. Okay, so if NADPH enzyme defect means the gene is FOX gene. Okay, FOX gene defect. Okay, so this FOX gene, since I told you this NADPH is having multiple parts, so some parts are present in cytoplasm, some are present in membrane. So any defect in cytoplasmic or membranous part will have defect in NADPH oxidase. Okay, so this is of two types. It can be X-linked recessive or it can be autosomal recessive. The membranous part, whenever will be defected, that disorder will be X-linked recessive. When the cytoplasmic part will be defective, defect will be autosomal recessive. Okay, so here the defect will be in glycoprotein 91. Okay, so the Fox gene glycoprotein 91 will be defected. For here autosomal recessive, other protein 41, 61, 51, all of those defected will be in autosomal recessive. Okay, other than this you have to remember what are the tests for this. So in this condition patient will have increased risk of catalase organisms infection. Okay, catalase organism, if you know, those are our staph aureus, all the pigmented one initially, serratia, pseudomonas. Okay, the fungus will be candida, enterobacteriaceae, all of those will be more common. Okay, so patient will have recurrent infection for all of those catalase positive organisms. So and the screening test for this, screening test will be nitro blue tetrazolium test. For the confirmation you have to remember RH, DHR test, dihydrorhodamine, which will be done by the flow cytometry. Okay, so for CGD you have to remember this has defect in an NADPS oxidase. The enzyme is Fox gene. Okay, this is having inheritance of two. X-linked recessive can be or autosomal recessive. If X-linked recessive, the protein defected is GP91. Autosomal recessive, then the protein will be 41 and 61. Okay, and the child is having increased risk of infection for catalase positive organisms such as S. aureus, serratia, pseudomonas, candida, enterobacteriaceae. Okay, and then there are few screening tests, that is nitroglutazolam test, and the confirmatory test will be the DHR test or dihydrorhodamine, which will be done by the flow cytometry. Okay, so here our acute inflammation is finished. So you have to remember all the clinical correlation of acute inflammation. Next will be the mediators. So I will just simply tell you what are the mediators. Detail you will study in your regular. Okay, so the mediators of inflammation are derived by the two. Either they can derive from the cell or they can derive from the plasma. The cell derived can be divided into two. Preform means those are stored inside the cell. Newly synthesized means whenever injury or inflammation is going on, only at that time they are synthesized. Those are newly synthesized. In the preform, we have main the three: histamine, serotonin, and our lysosomal enzyme. Okay. For the histamine, you have to remember this is mainly secreted by which cell? So histamine is secreted by one second. Okay, so for inflammatory mediators, you have to remember that from where which cells are synthesizing histamine. So for the histamine, you have to remember we have cells, most commonly that mast cell. Okay, mast cell are secreting histamine, which and other than mast cell is basophil. Okay, then what amino acid is the precursor for this? So histidine is the amino acid. Okay, and other than this, what are the functions? So serotonin and histamine having same function, that is vasodilation. So for inflammatory mediator, you have to remember whenever any blood vessel is getting vasodilated, so vasodilation indirectly leads to anti-platelet aggregation action. Okay, so this will not allow platelets to aggregate, so this will be the action. Okay, so whenever there will be more vasodilation, there will be more vascular permeability. Okay, so whenever these three will come together, or even I can say always these three come together, so whenever we will have vasodilation, there will be lack of platelet aggregation, and there will be more vascular permeability. Okay, so histamine and serotonin have having same function. For serotonin, you have to remember enterochromaffin cells are secreting maximum amount of serotonin. Other than this, tryptophan is the precursor for serotonin. Okay, that's why this is also known as 5-hydroxytryptamine. For lysosomal enzymes, you have to remember that they are lysosomal enzymes are having lysosomal enzymes are present in the granular form. Okay, so they are having primary, secondary, and tertiary granules. So the what are the components for primary granules? These are acid hydrolase, okay, collagenase. Okay, this collagenase is non-specific. Okay, so non-specific collagenase. Other than this, they are having defensin, okay, and elastases. All of these are present in primary granules. Then what are present in secondary granules? So these are having specific collagenase, which is mainly the type 4 collagen. Okay, so the enzyme which required to degrade the type 4 collagen of basement membrane is type 4 collagenase. Other than this, they will have myeloperoxidase, and they will have they will release only specific collagenase, mainly the specific collagenase. These cathepsin and myeloperoxidase are present in primary granules. For these tertiary or this tertiary granules, you have to remember gelatinase. Okay, so for primary, acid hydrolase and MPO, cathepsin, defensin, and elastase MPO. For type secondary, they are having specific collagenase. Okay, so this type 1 is also known as azurophilic granules. Azurophilic granules. Okay, this type 2 is also known as specific granules. Okay, type 3 is known as C peptides. Okay, so these are the different name for these granules. Okay, then in newly synthesized, you know nitric oxide. Nitric oxide is also known as endothelial derived relaxing factor. So this is the other name for nitric oxide. This is mainly synthesized from the L-arginine amino acid. Okay, so whenever on the L-arginine nitric oxide synthesis is working, they will form nitric oxide. Okay, this nitric oxide can be of many types like INOS, ENOS, and NNOS. Okay, INOS is inducible, which mainly required for the inflammation. Then we have platelet activating factor. This is the most potent vasoconstrictor. Okay, and this will allow platelet to aggregate because this is vasoconstrictor. Next is cytokines. Okay, for the cytokines, you have to remember these are our soluble peptides. Okay, so for the soluble peptides, you have to remember these can be divided into interleukin, they can have TNF alpha, and other type is interferons. Okay, for interleukin you have interleukin 1, which is mainly responsible for the fever. Okay, then we have interleukin 6, which is responsible for the control of acute phase reactants. Okay, then after can I write? Okay, interleukin 1 for fever, 6 for acute phase reactant controls. Okay, then there are 4 and 6. These are anti and pro, both means both anti and pro inflammatory. Then we will have interleukin 10. This is purely anti-inflammatory. Okay, so these are our main cytokines. Okay, other than this interleukin 10, we will also have anti-inflammatory, that is TGF beta, transforming growth factor beta, which is the most fibrogenic cytokine. This TNF alpha will be more in the septic shock condition, and more secretion will lead to decrease in appetite. So in the cancer, when there is more secretion of TNF alpha, will lead to cachexia. So how it will lead to cachexia? By decreasing appetite. These interferon can be divided to alpha, beta, and gamma. Okay, alpha is mainly for the antiviral action secreted by the leukocyte. Beta is also antiviral but less than alpha, and this is used in the treatment of multiple sclerosis in the brain. This gamma mainly secreted by the T helper 1 lymphocyte, and this is for the granuloma formation. Okay, so these are our cytokines. For the chemokines, you have to remember these. So chemokines, the first type is CX3C. Okay, so the example for CX3C is fractalkane. For next one is CXC. Okay, in the they have they have cysteine residue in their structure. Okay, so CXC, that is alpha, having interleukinate. Interleukinate is required for the neutrophil recruitment. CC is beta. This is having these three: eotaxin, rentacin, and MIP1 alpha. Eotaxin require recruitment for eosinophil, Rent is for T lymphocyte, MIP alpha for macrophage or monocyte. C is gamma, this is lymphotectin, means it's recruiting the lymphocyte. Okay, so these are our chemokines. In chemokines, we have these two species: CXC R4, CCR5. These are for the receptor for HIV/AIDS virus. Okay, so these are the chemokine receptor for HIV/AIDS. Okay, other than this, we have arachidonic acid metabolite. If you know, if COX enzyme or cyclooxygenase will work, they will form prostaglandin and thromboxane A2. If LOX or lipooxygenase will work, they will form leukotrienes. Okay. Then if uh, like if other pathway or eco non-enzymatic pathway will work, then they will form ecosa tetroenoic acid or EET. Okay, so these are all required for the inflammation. So these are our all enzymes. Okay, these are all our mediators. Okay, from the plasma, the liver is synthesizing and sending them to the plasma. So the coagulation pathway will come, kinin system will come, and complement will come. In the coagulation, if you know extrinsic pathway we are having, intrinsic pathway we are having. How coagulation pathway will help in inflammation? By the thrombin formation. So this thrombin is also in helping in inflammation. So we are so the coagulation pathway will also come as inflammatory mediator. In kinin, if you know bradykinin, okay, bradykinin is for pain. So bradykinin is also for the inflammation. These complement, if you know these complement, we have three pathways: classical, alternate, and mannose binding lectin pathway. Okay, so all of these will help in the process of inflammation. So these are our inflammatory mediators. Okay, so here full summary for inflammatory mediators. Next is chronic inflammation. So for chronic inflammation, which is the most important cell, so for chronic inflammation, we have most important cell, that is our macrophages. Okay, what is the hallmark feature for this? So the tissue damage and repair. This will be the hallmark feature for chronic inflammation. Okay, so this chronic inflammation has subtype, that is granulomatous inflammation. This is a type of chronic inflammation. So what are granulomatous inflammation? They are having granuloma formation. Okay, so what is this cell most important for granulomatous inflammation? This is epithelioid cells. Okay, so epithelioid cells are type of macrophages. These macrophages are having slipper shaped nucleus and slipper shaped nucleus. Okay, so this structure you can see, this is the representation of granuloma. So in the center we have necrosis. Around the necrosis we are having macrophages. Other than macrophages we are having epithelioid cells. Other than epithelioid cell, more outer we have giant cells. Okay, so what are the giant cells? They are the cells which are having multiple nucleus. And in the last, we have lymphocyte, and these lymphocyte are our T helper 1 cells. Okay, so the granuloma can also be divided into many types. Suppose some granuloma will not have any necrosis, then this is non-caseous, will not have any caseous necrosis, then that will be non-caseating. If this necrosis is caseous, then this will be caseating granuloma. Other than this, if this lymphocytic color is present, these are granuloma. If this lymphocytic color will be absent, then those will called as naked granuloma. This layer will be, or this T lymphocyte will be absent there. Other than this, you have to remember the different name of macrophages. Like in bone, we have osteoclast. In brain, microglia. So macrophage in different organs, they have different names. Okay, for lungs, we have dust cell or alveolar macrophage. For spleen, littoral cell, liver, Kupffer cells, kidney, messenger cells. So all of those names you have to remember. And then what are the types of giant cell? So for the giant cell, first type is when nucleus is arranging in a horseshoe pattern, this half moon pattern. This is our Langhans cell. Okay, so this is our Langhans cell. This here you can see the under the slide. So how the all the nucleus are arranging in the one side in the horseshoe pattern. This is our Langhans cell. We will see mainly this in the inflammation with the or infection with the TB. Okay. Then next cell you can see these all nucleus are present in the wreath-like pattern or in the circular pattern, and in the cytoplasm we have some gaps or these white areas. These are our Torton's giant cell. Okay, these Torton giant cell we will see in the condition of xanthoma. Okay, so in the xanthoma, these areas are having fat. So whenever we are trying to stain with HND, fat is not getting stained. So those areas will look like empty. So here you can see these nuclei are arranging in the circular manner and they have some small vacuoles. These are our total giant cell. Okay. Then next is these all nucleus are present in half a chart any direction any direction. These are our foreign body giant cell which you will see in the condition of any suture. Okay, or any other tall powder or something, we will see foreign body giant cell. Then next is these cells. Here you can see in the this cytoplasm is having multiple cells. Okay, multiple granules and they are having dot like appearance in the center. This is Bardeen Finkelday giant cell. Okay, this is Bardeen Finkelday giant cell. We will see this in the condition of measles. Okay, other than this we have tumor giant cell. In the tumor giant cell, this is our Reed Sternberg cell. Okay, so Reed Sternberg cell. So whenever we have mirror image nuclei, okay, mirror image nuclei and having the nucleoli is pink or eosinophilic, that is Reed Sternberg cell seen in Hodgkin lymphoma. But whenever these in inner area or these nucleoli are basophilic, and in the cytoplasm we will see multiple types of inclusions. This will mainly seen in cytomegalovirus infection. So here you can see there are multiple granules or inclusions present in the cytoplasm, and this area is more blue. These are our cytomegalovirus giant cell. Okay, these are also known as owl eye cells. Okay, so we have two owl eye. If inner is pink, that is Reed Sternberg seen in Hodgkin lymphoma. If we have inner is blue, that is seen in cytomegalovirus. Okay, next is the types of granuloma. For the types of granuloma, you have to remember few things. So for the types of granuloma, first thing is what is the granulomas? These granuloma are divided into two, infective and non-infective. Means one is infection. So that because of infection, we have in TB. So in TB, we will see more caseating granuloma, but we can also see non-caseating granuloma. Okay. Other than this, leprosy, we will see granuloma. In syphilis, mainly in the tertiary syphilis, we will see gammas. Okay, those are also granulomas, and these gammas are having plasma cells. Okay, so you have to remember plasma cells in the granuloma seen in tertiary syphilis. Stellate granuloma means this is star-shaped granuloma. This is star-shaped granuloma. You will see this under cat scratch disease. Cat scratch disease. Okay, this will be caused by the Bartonella henselae. Okay, donut granuloma. So this donut granuloma you will see in Q fever, which will be caused by the Coxsackie burnetii and one drug that is allopurinol. This will cause donut granulomas. Dark granuloma will be seen in malaria, mainly in the Plasmodium falciparum. So the first one is stellate granuloma. You can see this star shape. In the outer corner, they are having, in the outer part, they are having more neutrophils. Okay. Then this is our caseating granuloma. You can see this is our caseous necrosis. Here we also have these giant cells which are arranging in horseshoe pattern, Langerhans giant cell, and then epithelioid cell and the covering with the lymphocyte. So this is our typical appearance for TB. Okay. Then next, this is our donut granuloma. In the center, we will not see anything. In the surrounding area, we will see. So this looks like donut. So this is donut granuloma. So these are our granuloma related to infective disorder. Okay. Non-infective, we will see in sarcoidosis. So in sarcoidosis, you have to remember, we will see naked granuloma. We will also see granuloma, which is more non-caseating. Okay. And other than this, if you remember, there are some asteroid bodies. Plus, we can also see uh, asteroid bodies and Softman cells. Okay. Other than this, non-infective, we can also see in giant cell arthritis, or in, you can say, vasculitis, and in Crohn's disease, inflammatory bowel disease. So these are our types of granulomas. Okay. So here we will finish all our chronic inflammation. So now we will start with our wound healing. Okay. So for the wound healing, there are two. The wound healing can occur by the two types: primary intention or secondary intention. So whenever we are having any surgical incision scar, the healing by the process of primary intention. But if we are having bad scar, okay, big scar having irregular margin, then the healing by the secondary intention. Okay, in the secondary intention healing, we have more scar. This scar will be reduced inside by the myofibroblasts. Okay, so these cells are contractile cells. These are helping the contraction of the scar. Okay, now what is the hallmark feature for repair? That is granulation tissue. Okay, so granulation tissue means this tissue is having more blood vessel, fibroblasts, and inflammation. Okay, so for repairing also we need inflammation. So these three features will be present in granulation tissue. So here you can see how so many blood vessels we are having. So these are our all blood vessels. So in the tissue we will be having more blood vessels and more inflammation and more fibroblasts, which will help in the repair of our injury. Okay, now we will see some events of our injury repair. So injury will happen on the same day, day zero, we will having more platelets and fibrin at the site of injury. Then there is formation of blood clot and neutrophil on the day one. Then blood clot and neutrophil plus there is a thin layer of epithelium we will see in the day three. On the day five, we will see more starting of granulation tissue. So granulation tissue will appear on the day 5 along with collagen and macrophages will appear. We will see maximum granulation tissue will be maximum granulation tissue. Okay, so okay, 0, 1. Okay, this is 2, this is 3. Sorry. Day two, we will be seeing more neutrophils. Day three, we will be seeing more macrophages and collagen tissue. And day five, we will have maximum granulation tissue. And the collagen maximum we will see on the day 21, or I can say in the third week. Okay. So on the day of injury, on the day zero, we will be having platelets more and fibrin more. So what are the most or the first cell to come for repair? Those are our platelets. Okay, first cell to come at the site of injury is platelets. Then day one we will have blood clot and neutrophil. Then day two we will have more blood clot or stable blood clot, neutrophil plus thin epithelial layer. Day 3, granulation tissue will appear along with macrophage and collagen. Day 5, we will have maximum granulation tissue. Along with that, bridging of scar will appear and more neovascularization will be seen. And day 21 and day or third week, we will have maximum collagen. Initially, collagen type 3 will be forming and this will convert it into type 1 because type 1 is the most stable. Okay. Other than this, you have to remember bone strength. Okay. So for bone strength, you have to remember for at the end of 1 week, you will have only 10% strength. At the end of 12 week, or I can say 3 month, okay, we will have 70% bone strength. Okay, and if they will ask you when you will achieve 100%, so once injury will happen, we will never achieve that 100% of bone strength. Okay, so this is our bone healing. Other than this, for wound healing, you have to remember that most common cause of improper or not proper wound healing, that is infection. Other than this, if anybody is having vitamin C deficiency, then there will be defect in the collagen synthesis, so there will be delayed wound healing. And zinc deficiency will also lead to delayed wound healing. So these are few factors for delayed wound healing. Suppose somebody is having excessive wound healing, means excessive either granulation tissue they are having more, or they are having more scar, that we have different. Okay, so if they are having more granulation tissue, this is called as proud flesh. Okay, and if somebody is having more scar, then this can be two type, hypertrophic or keloid. For hypertrophic, you have to remember it will obeys their margin. Okay, so wherever we have incision, it will obeys their margin. Okay, it is self limiting, it will disappear by their own. Okay, so it will present only in the area of injury. Keloid, it will not obey the margin, it can spread. Most common site is sternum. You can see also in the ear lobule. And for the treatment, you have to give intralesional triamcinolone or steroid. If we have refractory, then we can use radiotherapy and surgery. Okay, so first we need to cut, then we will give radiotherapy. So this is how we can treat our excessive scars. Okay, so this is all about inflammation. Okay, in this chapter we have remaining like cellular injury. So what cellular aging? So cellular aging, the most common cause for cellular aging is free radical injury. Okay, why? Because these free radical will lead to lipid peroxidation. So this lipid peroxidation will lead to cellular aging. Okay, second most common cause for this is telomere shortening. Okay, so if you know, in our chromosomal end we are having telomere. After every division, this telomere getting shortened. So this will lead to telomere shortening and lead to the cellular injury. Okay, other than this, I have made one graph. So the cells which are having more telomere, they can divide more. So those cells which will never get aged, those are our germ cells. Means they are having enormous amount of our telomere. Okay, other than this, those cells which are having, like after some time they have decrease in amount. So these are somatic cells, and these are our stem cells. Okay, so after or age is increases, their telomere is decreasing, and they will have cellular aging. Okay, other than this, if any somatic cell after coming to the down slope, they are starting increasing, means they are having any kind of malignancy or tumor, because tumor will have more acquired telomere action. Okay, so this is our graph. Now how other than this, you have to remember what is the sequence of telomere. So for the telomere, the sequence is TTAGGG. Okay, so this is the sequence for telomere. Okay, then there is one concept of Hayflick's limit. Okay, so every telomere can divide up to 50 to 70 division, or every cell, those telomere can do 50 to 70 divisions. Okay, other than this, how we can increase our telomere, or we can increase our sirtuins. So this, for sirtuins we have SIRT genes. These sirtuins work as histone deacetylase, means they are deactivating our DNAs. Okay, so if we have to increase sirtuins level, we have to decrease the amount of calorie intake. If we will eat less calories, sirtuins will increase more, we will have delayed aging. Other than this, we can also use red wine. Okay, so how to decrease calorie, how increase calorie is causing aging, because whenever we are taking more calories, there are more IGF-1, insulin growth factor 1. This insulin growth factor 1 will lead to more activation of mTOR. mTOR is for the proliferation. So if cells start proliferating more, this will have more injury, and injury then lead to cellular aging or early cellular aging. Okay, so if we can restrict our calorie, we can increase our sirtuins. These sirtuins will help us in anti-aging. Okay, then other than this, we have TERT gene. Okay, TRT gene, which will elongate our telomere. Okay, so mutation with this gene we will study under our tumor known as primary glioblastoma, brain tumor. Okay, so mutation of this gene will lead to primary glioblastoma or short telomeres or shortened telomeres. Early shortened telomere will lead to dyskeratosis congenita. Okay, so if somebody is having short telomeres, they will have condition dyskeratosis congenita, and those genes which are uh, growing or keeping the telomere elongation or doing the telomere elongation, mutation of that leads to primary glioblastoma, means the cancer of brain, tumor of brain. So this is our cellular aging. Okay, for this cellular aging you have to remember how free radical injury will occur. So this oxygen, when it will come inside the cell by the any toxin or any other bacteria virus product, it will convert it into superoxide. By the help of superoxide dismutase, it will convert it into hydrogen peroxide. Okay, then this hydrogen peroxide, this will in the presence of iron or copper will be converted to hydroxyline. This is the most potent free radical. Okay, and this reaction where we are converting ferrous ion to ferric ion, this is known as Fenton's reaction. Okay, so these hydroxyline will go and do lipid peroxidation and patient will have more aging. Okay, so this is cellular aging. We have few enzymes which can reduce these free radical formation, like here we have catalase. This catalase enzyme will convert hydrogen peroxide into water. So catalase is safe for us, which will reduce the cellular free radical injury. Other than this, we will have glutathione reductase, which will convert all of these into the water and save our RBCs, and all of those process will come here. So two enzymes, if they will ask you, one is catalase, which is protective for us. Glutathione reductase will be protective for us, and we will have other antioxidants like vitamin A, D, E. All of these will be antioxidant and they will decrease our aging because they will decrease formation of free radical injuries. Okay. Next topic is intracellular accumulation. So what are the substances can accumulate inside the cell? They can be pigment, they can be our these calcium. Okay, so first we will come to the calcium. So how calcium will accumulate? So for the calcium we have three stains: von Cosa stain, alizarin red stain, calcium stain. Von Cosa will give calcium black color, alizarin red will give red color. Okay, and this will use for the small quantity or minute quantity of the calcium. So if I want to check minute quantity of calcium, then I will use alizarin red. Okay, so this will use for minute quantity of calcium. First place where calcium will deposit, what is the first place? So this is mitochondria. Okay, so in the body's all cell, first calcium will deposit in the mitochondria, except in the kidney it will deposit more commonly into the basement membrane. Okay, so this is the first place. Now this calcification is divided into two categories. First category is dystrophic calcification, other is metastatic. So dystrophic means this is, here calcium amount will be normal. So if patient is having normal amount of calcium, it will deposit. Okay, so it's seen in those areas where we have dead tissues. Okay, so in the dead tissues, if calcium is depositing and we have normal amount of calcium, that is dystrophic calcification. So we will see this in any dead parasite. So any dead parasite location, any inflammatory location like in TB lymph nodes. Okay, other than this, we will see this in Samoma bodies. We can see this in Samoma bodies. And can you tell me where we will find Samoma bodies? And Samoma bodies, other than this, we will also see this in those dystrophic tissues or degenerative tissues. Okay, so these are our, yes, PSM. Okay, so what is the full form of PSM? P for papillary carcinoma of all the papillary carcinoma. Okay. S for serous cyst adenoma. M for meningioma and mesothelioma. Okay, so all of these area we will see our dystrophic calcification. Other than this, we can also see in Monkeyberg sclerosis. Monkey sclerosis, okay, or calcific median degeneration, which is a old age disorder. Okay, metastatic, in metastatic serum calcium will be more. So if serum calcium will be more, most common site of deposition. Okay, so most common site of deposition will be the lungs. Okay, and examples, what are the example for this? So if you know renal stones, all of those conditions, like in hyperhypoparathyroidism, all of those conditions we will see our this metastatic calcification. So for metastatic calcification, you have to remember we have more amount of calcium. More amount of calcium will go and deposit. So we have more uh, more deposition of calcium. Okay. Other than this, most common site of calcium deposition, more common site of calcium deposition will be lungs. Okay. In vitamin D intoxication, sarcoidosis, all of those conditions will also lead to sarcoidosis will also lead to metastatic calcification. Okay, for dystrophic, I have told you dead degenerative tissue, samoma bodies, and Monkeyberg sclerosis. All of these conditions will show us dystrophic calcification. In dystrophic calcification, serum calcium will always be normal. In metastatic, serum calcium will be more. Okay, this is all about calcium. Next will be copper. For copper, we have two stains. One is rubinic acid or rubinic acid, and rhodanine. Okay, so rubinic and rhodanine. For copper associated protein, we have ornithine stain. Okay, so for copper, rubinic, rhodanine, and ornithine stain. Okay, next is glycogen. For glycogen, we have pastane. Okay, this pastane is periodic acid strip test, which will give glycogen pink color. Okay, for the pastane, we have to remember some materials or some components are pass positive, diastase sensitive. Okay, DS means diastase sensitive. Okay, so what does it mean? So whenever we are staining with pass, they will give us pink color, but then when we are putting diastase over them, they will not show any pink color. So initially they are pink, after that putting diastase, they don't show any color. Those are diastase sensitive, means those glycogen will be digested. Okay, so the example will be glycogen. So glycogen is only structure which is pass positive and diastase sensitive. Rest other structures are pass positive diastase resistant. Okay, so other molecules are pass positive diastase resistant. So for glycogen, you have to remember, we will see this. Suppose somebody is having, one child is having glycogen storage disorder, or I can say von Gierke disease. Okay, so in von Gierke disease, they will have more glycogen deposition. So the more pass positive diastase sensitive we will see. Ewing sarcoma and genital cancer like dysgerminoma and seminoma, we will see pass positive diastase sensitive, because in all of these conditions we are having deposition of more glycogen. For pass positive diastase resistance, we will see in alpha 1 antitrypsin, ALL, okay, AML, M3, M6, and M7, amyloid, because amyloid is pass positive but diastase resistant. In basement membrane also, colloid, Whipple disease. In diabetes mellitus, those Kimmelstein Wilson lesion will also pass positive diastase resistance. And also in some fungus, those all structures are our pass positive diastase resistant. So simply if they will ask you what are the structures are pass positive, then you will remember all. If they will mention diastase sensitive, means only one glycogen. Diastase resistant can be other also. Okay, so for this is our glycogen. Next is lipid. So for the lipid, you have to remember most common organ for lipid deposition is liver. Okay, if it will deposit in heart, then that is appearance is called a tabicat or tigeroid appearance. Okay, so why? Because they have some normal muscle then some fat deposition. So this yellow is fat. Again, this normal muscle. Again, this. So this is called as tabicate or tigroid appearance of heart. Then next is the stain for lipid is oil red O, Sudan black B. Other than this, you will have Sudan 4 and you will have osmium tetroxide. The section we are using for this is cryostat. Okay, so we are using cryostat for the lipid sectioning. Okay, so oil red O, whenever we are putting oil, this stain over the fat, this will give red color. Whenever we are putting Sudan black B, this will give fat as black color. Okay. Next is hemosiderin. If you know, hemosiderin came from the heme. Okay, so heme means more iron. So the staining for the hemosiderin will be pulse stain or Prussian blue. It will give blue color. Okay, and the pigment is yellow brown and refractile. Okay, it will be shining pigment. Next is melanin. So if you know, melanocytes are present in the basal part or basal layer of skin. These are brown black pigment in the HND staining. So here you can see this basal layer. They all are brown black. So this is our melanin. To confirm the melanin, we will put special stain. So first special stain is Mason Fontana, which will give black color. Then small stain will give blue green color. We have one immunohistochemistry marker, that is HMB45 for melanin, and the special stain for melanin is dopa oxidase. So they will ask you, like, some one patient is having bluish black growth on the hand. Okay, and it is having irregular margin, everything they have mentioned, and they have mentioned that the histochemistry marker they have found is HMB45. Okay, now what is the diagnosis? So if HMB45 is present, means the diagnosis will be malignant melanoma, means the cancer of melanocyte. So by all of these 10, you can remember the main diagnosis. You can lead to the ultimate diagnosis. So these are stains for our melanin. Next is lipofuscin. Lipofuscin, if you know, it's also called as BRNTR pigment or old age pigment, or also known as telltale sign of free radical injury. Okay, and this is a perinuclear yellow brown pigment present perinuclearly. Okay, and this is due to the lipid peroxidation. So whatever stain we are using for the lipid, we can use here. So our stain for lipofuscin will be oil red O, means this will give red color, and these are also Jaden stain positive, or I can say acid fast positive. Okay, so these are all our intracellular accumulation. Okay, so for intracellular accumulation, you have to remember calcium, copper, glycogen, and after glycogen, we will have lipid, hemosiderin, melanin, and lipofuscin. All of these are, you have to remember with their stains. Okay, so here we have almost finished our inflammation. The last few confusing terms I have mentioned it at one place. So first is nets. Nets means neutrophil extracellular trap. Okay, so this is the process of killing extracellularly in the blood. This will mostly seen in the condition of sepsis. When we have lots of bacteria virus in the blood, the neutrophil will condense their chromatin and spread out. So it will lead to obstruction of all these organism inside these chromatin, and this will lead to the inflammation process. Okay, or phagocytosis. Other than this, this is a we will also call this as beneficial suicide. Okay, why beneficial suicide? Because to save our body, neutrophils are dying. So with this is beneficial suicide. Okay, so this is beneficial suicide. Other than this, in the end of this process, neutrophil will die. Okay, this is extracellular. The amino acid used here is arginine. Okay, so by the arginine deaminase, this arginine is converted into citrulline. This citrulline is utilized for the neutrophil to condense their chromatin. Other than this, they have association with SLE, because there is lots of chromatin is coming out in the blood, and chromatin, if you know, not our this is our privileged side, means this chromatin is always present inside the cell. Now when this will come out, more antibody will form against this. Those are anti-nuclear antibodies. They can be double stranded DNA bodies. All of those will be formed. So the association of nets will be SLE or systemic lupus erythematosus. So this is nets. Next is entosis. Okay, Entosis means I have one cell, nearby one cell. This cell, by the help of cadherin, will go inside the other cell, and inside that cell, this will be degraded. That is entosis. So one cell inserts itself into the neighborhood cell and lead to the death of those invading cell. That is entosis. Next term is epherocytosis. Epherocytosis means those apoptotic bodies will be engulfed by any macrophage. That process is called epherocytosis. Okay. Other than this, one more confusing term is emperipolysis. Emperipolysis means one cell is coming inside the other cell, and this cell is not killing this cell. This is just simply sitting with the other cell, or I can say simply cell within the cell is emperipolysis without any killing. Okay, we will see this in myelodysplastic syndrome, autoimmune hepatitis, Rosai-Dorfman syndrome, and chronic lymphocytic leukemia. Okay, and this is the example, or this is the cell. You can see here one cell is present inside. So this is our emperipolysis. Okay, so if they will ask you phagocytosis, so phagocytosis is intracellular. Okay, and there will be killing of the cell, or killing of the those of whatever they are engulfing, killing. Okay, in the next, this is extracellular and killing by the releasing of chromatin with the help of citrulline. Okay, and this is associated with SLE, and in the end, neutrophil will die. In entosis, one cell is trying to invade into the other cell or the neighboring cell, and inside that neighboring cell, the cell is dying. That is entosis. Epherocytosis means all those apoptotic bodies formed during the apoptosis process, they are engulfed by the macrophage. Those are called as epherocytosis. Okay, and emperipolysis means cell within the cell. So one cell is present in the other cell, inside the other cell, and not getting killed by those cells. Those are emperipolysis seen in all of these conditions. So myelodysplastic syndrome, autoimmune hepatitis, Rosai-Dorfman syndrome, chronic lymphocytic leukemia. Okay, so this is all about cell injury and inflammation. Okay, so now we will be starting with our chapter immunology. Okay, so in the immunology, we will be keeping it very short. So we just need to remember the marker. So what is CD34 is the marker for hematopoietic stem cells. Okay, so the marker for hematopoietic stem cell is CD34, and this is also the marker for endothelium. Okay, other than this, MPO, CD13, CD33, and CD117 is the marker for myeloid precursor. Okay, then CD19 to CD23, CD40, B7, CD79, CD17B. This is the marker for B cell or B lymphocyte. CD128, CD28, CD40 ligand is the marker for T cell or T lymphocyte. CD8 is the marker for cytotoxic T cell. Okay, CD4 is marker for helper T cell. Okay, CD25 and FOXP3 is the marker for T regulatory cells. Okay, and this CD25 is also known as interleukin 2 receptor. Okay, and this CD16, 56, and 94 is the marker for NK cells or natural killer cells, also known as large granular lymphocytes or non-B, non-T cells. Okay, so these are marker for natural killer cells. What is the pan T cell marker? So pan T cell marker is CD3. Pan B cell marker is CD10. CD21 or CR2 on the B cell is the receptor for Epstein-Barr virus. That's why these Epstein-Barr virus can lead to lymphoproliferative disorder or many cancer because it will activate B cell. CD10 is Kala antigen or common ALL antigen. So CD10 is common ALL antigen. So these are all our CD markers. Okay, now we will come to hypersensitivity reaction. Okay, so for hypersensitivity reaction, this according to the Gell and Coombs classification, they are divided into 5 types. Okay, so type 1, if I will write it all here, 1, 2, 3, 4, and the 5 one is the newly one. Okay, These starting three are mainly the antigen, antibody mediated, or I can say antibody mediated. Type 4 is cell mediated immunity or delayed immunity. Type 1 is immediate, okay, immediate response. Other than this, you have to remember in the type 1 we will have in the type 1, the antigen is free, okay, antibodies are fixed, they are present over mast cell, okay. This type 1 hypersensitivity reaction occurs in two phases. In the early phase, suppose somebody is getting exposed to pollen first time. If they are exposed to pollen first time, then the antigen presenting cell take that pollen, they will show to T helper cells, then these T helper cell will take them to the B cell, and then B cell start producing antibodies. Those antibodies will go and sit on the surface of mast cell, okay. So this is the first exposure. In the first exposure they will have very less symptoms, but as soon as they have second exposure to the same, then they will have they will those antibodies present on the new present on the mast cell, they will interconnect with themselves, and they will lead to the earlier degranulation of the mast cell, and they will have more severe symptoms. So most important cell for the or most important cell for the type 1 hypersensitivity reaction is the mast cell. Most important in the late stage will be the eosinophil, because in the later part, when we will have more cytokines, they will attract more eosinophil, and then eosinophil will come and they will release mannose binding proteins, okay. Then the example for type 1 hypersensitivity reaction will be atopy. If you know, atopy is related to chromosome number 5. So the allergies running in the family associated with chromosome 5 are atopies. They can have allergy like allergic rhinitis, conjunctivitis, allergic rhinitis, conjunctivitis, dermatitis, all of those will come here. Then patient with asthma, they will have type 1 hypersensitivity reaction. Cassoni test, we are doing this for hydrated cyst. This will also, this is now obsolete test, but this will come under type 1 hypersensitivity reaction. In drugs also, like drug allergy, like penicillin or other drug allergy will also come under type 1 hypersensitivity reaction. Other than this, all the anaphylactic reaction will also come under type 1 hypersensitivity reaction, okay. Then the type 2 hypersensitivity reaction, type 2 hypersensitivity reaction, antigen is bound or present on this somewhere, and now antibodies are free, okay. So if antibodies are free, they are going to the antigen and they are binding there, okay. So the first example is myasthenia gravis, other one is blood transfusion reactions, Graves disease, good pasture syndrome, rheumatic heart diseases, immune immune hemolytic anemia, immune thrombocytopenic purpura, Rh incompatibility, pemphigus vulgaris, pernicious anemia. So all these are examples of type 2 hypersensitivity reactions. Okay. In the type 3, this is mainly mediated by the immune complex deposition. Now, antigen and antibody both are free. If they are free, they will form a complex, and this complex will go and deposit in the body. So the first example is SLE. In SLE, we have lots of antibodies, and they are going to deposit, and they will lead to lupus nephritis, purpura, petechiae, all of those because of SLE. Serum sickness, Hinox-solent purpura, IgA antibody get deposited into the blood vessel. Arthros reaction means localized immune complex disease. Sick test, okay. Raji assay, reactive arthritis, post-streptococcal glomerulonephritis, polyarthritis nodosa, and some parasitic diseases, okay. Like malaria is causing nephropathy, those are parasitic disease. So these all comes under type 3 hypersensitivity reaction, where antigen and antibody are free and they are forming complex, and this complex is causing disease. Those will come under type 3. For the type 4, this is cell-mediated immunity, delayed hypersensitivity reaction. Most common cell is T helper 1 cell. So if T helper 1 is involved, there is lots of interferon gamma. More gamma means more granuloma. Okay, na? So simply all those diseases which are having granuloma like TB, sarcoidosis, okay, leprosy, Okay, leprosy and other disease, all wherever we will find these syphilis, wherever we will find all of these granuloma, they will have type 4 hypersensitivity reaction. Okay, and those diseases, skin tests will also come under this, like Montus test for the TB, lepromin for leprosy, and Montenegro we are doing for Leishmania. Okay, Leishmania, Donovan, Leishmaniasis. So this is our comes under type 4 hypersensitivity example. Other than this, contact dermatitis will come under type 4 hypersensitivity reaction. In India, now leading cause for contact dermatitis is those our artificial jewelries which are having copper in them. Okay, arsenic and copper in them. Okay, so this is our contact dermatitis. Other than this, we have some controversial like in SLE. In SLE, we can see type 2 hypersensitivity reaction because it is showing immune hemolytic anemia, and type 3 also. Okay, but if they will ask you single answer, then the answer will be type 3. So in these cells, it is showing type 2, in the blood, it is showing type 3. So they are saying it is a combination of type 2 and type 3. For rheumatoid arthritis, also same type 4 and type 3 we can see both, but more common is type 3. For hypersensitivity pneumonitis, same 4 or 3 we can see any. For the lepra reaction, you have to remember for lepra reaction we have two, type 1 lepra reaction, type 2 lepra reaction. Type 1 lepra reaction is showing type 4 hypersensitivity, type 2 will show us type 3 hypersensitivity. For them, we need to combine them, like 1 plus 4 is equal to 5, 3 plus 2 is equal to 5. So we have to, in the end, we need 5 as the answer. So type 1 for 4, type 2 will show type 3 hypersensitivity reaction. Okay. Now the newly discovered is type 5. So all those antibodies which are against any cellular receptor, those come will under type 5. So now myasthenia gravis, according to the newer classification, will comes under type 5. So if they will give you in the option type 2, not type 5, then you will answer type 2. But if they will give you type 2 and type 5, then you will answer type 5. Okay. Myasthenia gravis is the antibody against acetylcholine receptor present on the post synaptic terminal. Okay, and the Graves disease is antibodies against TSH receptors on the thyroid gland. So these are our examples of type 5 hypersensitivity reaction. So they have antibody against particular cellular receptors. Now we will come to the in the transplant immunology. I will just tell you the transplant rejection. So the hyperacute rejection will comes at the time of intraoperative period. This have type 2 hypersensitivity reaction, and these antibodies are preformed antibodies. Those preformed antibodies are mainly seen in the patient which are already having multiple blood transfusions, or they are multi parents, or they are having multiple kids, so they have multiple exposure to different antigens, so they are already having preformed antibodies. As soon as we are putting our graft inside them, they have rejection, that is hyperacute rejection. So intra op only we can see cyanosis of that structure. The acute rejection will be occur after weeks or months. It is divided into two. It can be cellular or it can be humoral. If it is by the cells, the hypersensitivity reaction they will show is type 4. If it is by the humoral, means by the help of antibodies, then this will be type 2 hypersensitivity reaction. And the immunohistochemistry marker will be C4D, and they will have tubulitis, endothelitis, all of these conditions we will see here. In chronic, this will come after years. Most common hypersensitivity reaction is type 4 hypersensitivity reaction, and they will show tubular atrophy. So these are our transplant immunology. Next, we will also have one graft versus host disease. In this condition, the graft is immunocompetent, means good immunity. The host is immunocompromised. So now these graft cells start targeting our host cells. So this is graft versus host disease, which will show type 4 hypersensitivity reaction. So these are all our transplant immunology. Other than this, you have to remember what type of grafts we are having, like allograft, isograft, and xenograft. All of those are grafts, and HLA marker also. If you can remember all of these things, you can remember. Next is immunodeficiency disorder. So for immunodeficiency disorder, you have to remember they are divided into two. primary and secondary. For primary, you have to remember that for secondary, you have to remember that most common cause of immunodeficiency is malnutrition. Okay. Other than this, patient with HIV/AIDS, they will have immunodeficiency disorder. Patient with cancer, they can show immunodeficiency disorder, and patient on radiotherapy or chemotherapy, they will also show us immunodeficiency disorder. Okay. Other than this, we have categorized primary immunodeficiency disorder into three types. One is either defect in the maturation, or their defect in the activation of the lymphocyte, or the defect in the systemic diseases. Okay, so we will write what comes under the maturation. So if lymphocytes are unable to mature, then these disorders are severe combined immunodeficiency. Then the next one is our Bruton's A gamma globulinemia. Then other is DGeorge syndrome, and the last one is Behr lymphocyte disorder. Okay, so these all comes under the maturation defect of lymphocyte. For the activation, we have combined common variable immunodeficiency disorder. Other than this common immunodeficiency disorder, we have hyper IgM syndrome. Okay, we have isolated IgA syndrome. Okay, and X-linked lymphoproliferative disorder. These will come under the activation defect. Okay, in the systemic disease, we are having Biscott Eldridge syndrome, and also we are having ataxia telangiectasia. All of these will come under this. So we will start studying one by one. So first is severe combined immunodeficiency disorder. Okay, so severe combined immunodeficiency disorder means the disorder is of like having inheritance of two. Either it can be X-linked recessive or it can be autosomal recessive. The X-linked recessive is the more common type. In the X-linked recessive, defect will be seen in gamma subunit of interleukin 2, 4, 7, and 15. Okay, so if you know this, interleukin 4 is required for the isotype switching. Okay, isotype switching means initially the B cell are producing more IgM antibody, IgM and IgD. Then I want to change them to IgG or E or A, then we need interleukin 4. Okay, so if defect with interleukin 4 gamma subunit, there will be no isotype switching, but the B cell will be normal. In the interleukin 2 and 15, if you know, these are required for the natural killer cell activation. So if they are deficient, then natural killer cells are defected. And interleukin 7 4 we require for T cell activation. If this is defect, then T cell will not mature. So in X-linked recessive, we have main defect with natural killer cell and T cell. B cell will be normal and increase in amount. Only the antibody production will be hampered. The autosomal recessive is divided into three. First is deficiency of adenosine deaminase, which is the most common. So adenosine deaminase is required for the degradation of deoxyadenosine. Okay, so if adenosine deaminase is not present, deoxyadenosine start accumulating. If it start accumulating, it is toxic for the cell. Okay, so all the three types of cell, B cell, T cell, and natural killer cell, all will be defective here. Okay. Next is JAK3 defect. So JAK3 defect in gamma subunit, they will give signal to JAK3. Then JAK3 will send signal to like interleukins. Okay, so they are interconnected. So JAK3 defect means gamma subunit is normal now. JAK3 is not working. So here also we have only defect with T and NK cell. B cell will be normal. Okay. Then we have if defect in RAG1 and 2. Okay, RAG1 and 2, then RAG1 means recombinant activation gene 1 and 2. Then we will have defect with mainly with the B and T cell, natural killer cell will be normal. Okay, why? Because this RAG gene or RAG1 and 2 required for the B cell receptor formation, T cell receptor formation. If the receptors are not working, B and T cell will not work. So the defect with B and T cell, natural killer cell will be normal. Okay, so this severe combined immunodeficiency will can affect all the three types of lymphocyte. It is of two type: X-linked recessive, autosomal recessive. In X-linked recessive, the main defect with the gamma subunit. So if gamma subunit of interleukin 2, 4, 7, and 15 will be affected, then patient will have defect in natural killer cell and T cell, and the B cell will be normal, only the antibody production will be hampered. So now B cell will be more. In autosomal recessive, they have three defects. We can see three defects. One is adenosine deaminase, which is more common. Okay, so adenosine deaminase we require to degrade deoxyadenosine. If we don't have adenosine deaminase, more deoxyadenosine will accumulate and lead to toxicity of that cell. So B, T, and NK cell, all three will not work. Then next is JAK3 defect. For the JAK3 defect, the gamma subunit is interconnected with JAK3 to send signal inside the cell. Now JAK3 is not working, then the same problem interleukin 2, 4, 7, and 15 will not work. So T and NK cell will be defected, B cell will be normal. For RAG1, 2 means recombinant activating gene. These are mainly required for the formation of B cell receptor, T cell receptors. If B cell and T cell receptors are not working, not forming properly, B and T cell will have defect. Only natural killer cell we will found to have normal. Okay, so this is severe combined immunodeficiency. What will be the clinical features? So the patient will have morbilliform rashes, oral thrush means the candida infection, recurrent infection since birth, there will be absent germinal centers, and if we will give any live vaccine to the patient will have more severe infection. So if they will give you in history that one child has given, suppose mumps vaccine, and he is having more severe infection, then the patient will have SCID or this severe combined immunodeficiency disorder. Okay, so this is our uh, clinical feature of severe combined immunodeficiency disorder. Okay, for the Dijos syndrome, you have to remember this mnemonic catch 22. Catch 22 is the chromosome number 22. Okay, so this chromosome number 22 and okay, chromosome number 22 and the gene responsible. Okay, before this we have also one Bruton say gamma globin anemia. I have told you in inflammation, so I am skipping here. So DJOS syndrome is chromosome number 22q11. Okay, the gene involved is TBX1 gene. Okay, this gene is required. Okay, this gene is required for the neural crest cell to migrate. So patient will have these symptoms. One patient will have cleft lip, cleft palate. Okay, then A4 they have abnormal faces. From T, the patient will have thymic hypoplasia. The thymus will not develop properly, so patient will have T cell defect. And for the T, we have tetralogy of Fallot, the heart defect. From the C, or we can say cardiac defect. So this cardiac defect is also showing the same, and also hypocalcemia. Okay, from this H. Okay, so from C, cleft lip, cleft palate, from A, abnormal faces, from T, thymic hypoplasia and tetralogy of Fallot, or you can remember from C, cardiac defect, that is tetralogy of Fallot is more common. From H, hypocalcemia, because parathyroid are also not developing. This DJOS syndrome is also known as velocardiological syndrome. Okay, velocardiological syndrome. Here, our third, and fourth pharyngeal arch are defected because thymus and these parathyroid gland are developing from third and fourth arch, so they are defected. If they are defected, they are not forming properly parathyroid and thymus. Patient will have immunodeficiency disorder. The gene is TBX1 gene. Okay, next is hyper IgM syndrome. So here we have completed SCID, X-linked recessive, autosomal recessive. Brutans, I have told you that BTK gene defect more common in boys, B cell defect, lack of antibody. Okay, so defected opsonization. DJOS we have studied, catch 22q11 chromosome, TBX1 gene, cleft lip, cleft palate, abnormal faces, and thymic hypoplasia, tetralogy of Fallot, hypocalcemia. Bare lymphocyte is nothing, they don't have any receptors over them. Then next is common variable immunodeficiency disorder. Okay, before that we will study hyper IgM syndrome. Okay, so what is hyper IgM syndrome? So first I will tell you the normal. Suppose any, this is a B cell and one T cell. Okay, if this T cell wants to produce, if T cell wants to produce antibody, okay, then this T cell will ask this B cell to switch them. Okay, so this, how this will happen? T cell is having CD40 ligand and B cell is having receptor for CD40. This CD40, they will interact, this T cell will send signal to B cell, and these IgM antibodies are switching into IgG or A. So this is isotype switching by the help of our those interleukins. So this will help in the switching of the uh, antibodies. Okay, so we have, for isotype switching we have two things. We have interleukin 4 and 5 and our CD40 and 40 ligand interaction. Whenever they will happen, we will have isotype switching. So these IgM will be converted to IgG, IgA or IgE. Now suppose this patient is having defect in CD40 ligand. This ligand is not working, this ligand is absent. Now this interaction will not happen, then we will have more IgM. So this is known as hyper IgM syndrome. The second most common cause can be the CD40 receptor is defected. Okay, and this CD40 ligand is also known as CD154. Okay, so we will be, if we want to check this in the flow cytometry, how we can check? So simply I will draw one diagram. So here suppose this is our flow cytometry graph. Okay. Here we have CD154 and CD154 or CD40 ligand is present in T cells. So here CD3. We will divide this into three parts. Okay, so whatever are the normal cells, they are having more CD3, more CD54. So they will present here. If one cell is having very less CD50, CD154 and CD3, means these are, we cannot know they are T cell or they are not T cell. Okay, but those cells which are having more CD3 but they are having less CD154, means these cells are having defect in CD154 or CD40 ligands, means these are our hyper IgM syndrome cells. Okay, so we will find them here, somewhere here. And these are also having increased risk of pneumocystis infection, zero-basic or Carney infection. Next disorder is common variable immunodeficiency. Common means both B and T cell can be involved. So if B cell involved, the gene mutated is BEF gene. Okay. So the BEF gene mutation means these B cell will never getting converted to plasma cell because these they require BEF gene. If this gene is defected, plasma cell will not form, IgG will not form. But B cells are forming. We have mature B cell. So when we have more B cell, there will be hyperplasia of germinal center. Means we have B cell, but we are unable to form IgG. So continuous stimulation goes to this germinal center. So we will have hyperplasia of germinal center. Still we have IgG deficiency. This will be seen in CVID. The variant will be BAF gene defect. Other than this, we have ECOS defect. If ECOS defect, then there will be defect in the T cell. ECOS means co-stimulator molecules. Okay, so this is common variable immunodeficiency disorder, and the patient will have more infection similar to like Bruton's hypogammaglobulinemia, like Giardia, enterovirus, herpes, ecovirus. All of those infection will be more in this condition. Next is systemic disorder. Okay, so in this systemic we have Biscott-Eldridge syndrome. In the Biscott-Eldridge syndrome we have, this is a X-linked recessive disorder because this BESP gene present on the XP, okay, X chromosome P arm. So this is more common in boys, okay, early age. That we will see one triad in Biscott-Eldridge syndrome. We will have, patient will have recurrent infection, patient will have eczema and bleeding. Why bleeding? Because the platelet count and platelet size both will be decreased here. So Biscott-Eldridge syndrome will have recurrent abortion, recurrent infection, eczema, bleeding. Okay. If we will check antibody profile, we will have less IgM antibody, more IgA antibody and IgG will be found in normal. So this will be our Wiskott-Aldrich syndrome. Okay. Other than this, we have one is that is Job syndrome. Okay, Job syndrome or hyper IgE syndrome. Okay, here the defect will be STAT3 gene defect. Okay, this is mainly seen in age group like 17, 18, and they are problem with the T helper 17 cells. Okay, the T helper 17 cells. Patient will have abnormal feces. Patient will have cold abscess. Okay, and other than this, if we will check his this serum, then we will have more IgE in the blood, and the teeth will be abnormal retention of primary teeth, means patient will have primary teeth in the 17 years of age. So this is Job syndrome or hyper IgE syndrome. Okay. Other than this, if we I want to simplify this Bruton's and BAF, then we will have I will draw one diagram. This is our bone marrow producing pre and pro B cells. Okay, they are getting converted into mature B cells. Then these mature B cell will be converted into activated B cell. Those are our plasma cells, and they are producing our antibodies. Okay, now the problem is between here, like immature are not getting mature B cell, then the defect is BTK gene defect. This is our Bruton's A gamma globulinemia. But if B cells are not getting converted into activated B cell, the defect is BAF, and this is our CVID, common variable immunodeficiency disorder. But if somebody is having more IgA, okay, so this is called as somebody is having more, no, somebody is having very less IgA, or these IgA are not converting, or isotype is not happening, they are having selective IgA deficiency. This is selective IgA deficiency is the most common immunodeficiency disorder. Okay, the most common immunodeficiency disorder is selective IgA deficiency when isotype is not happening. Okay, so these are our all immunodeficiency disorder. Okay, other than this, last topic for today is amyloid. Okay, amyloidosis means deposition of amyloid. Amyloid is a misfolded protein deposited in the tissue extracellularly, not inside the cell, outside the cell. Okay, we have classified amyloidosis into two: primary amyloidosis, which is mainly the A amyloid light chain, seen in multiple myeloma. Okay, then rest other are secondary amyloidosis. For secondary amyloidosis, you have to remember, for secondary amyloidosis, first one is amyloidosis associated. Okay, so this A this A can be of two types. Either it can be due to mode deposition, or it can be due to mutation. Okay, mutant A or mode deposition of A. Okay, so if serum associated amyloid is more, this will be seen in chronic inflammation. Okay, any chronic inflammation like bronchiectasis, okay, or in cancers, okay, like Hodgkin lymphoma, RCC, all of those, because they are secreting more interleukin 1 and 6, they will stimulate more level, and they are producing more amyloid associated proteins. Okay, all chronic inflammation except chronic bronchitis. Okay, in this condition we are not having amyloid deposition. Mutated serum associated amyloid, this mutated serum associated amyloid is getting deposited in our getting deposited in familial Mediterranean fever. Okay, so familial Mediterranean fever is having familial Mediterranean fever is having mutated variant of serum amyloid associated. Okay, then ACAL you will see in medullary carcinoma thyroid, because calcitonin is secreted by the those cells. Okay, so the cancer of those cells, parafollicular cells, will lead to medullary carcinoma thyroid, and they have ACAL deposition. ATTR or amyloid transthyretin, this is also two types. If this is more deposition or this is mutated. Okay, more deposition we will see, or no deposition, or the wild type we will see in senile systemic amyloidosis, okay, or systemic senile amyloidosis. Mutated you will see in familial amyloidotic polyneuropathy. Okay, so in this condition you will see mutated variant of ATTR. A beta you will see in Alzheimer disease, deposition in brain, Alzheimer disease. A beta 2 microglobulin in dialysis related complications, you will see dialysis related deposition. Okay, and AIPP you will see in type 2 diabetes mellitus. AIAPP means amyloid in islets associated polypeptide. A amyloid ANP, atrial natriuretic peptide, you will see in isolated atrial amyloidosis. Okay, so all these are types of amyloidosis deposition. So primary is mainly one, a light chain, amyloid light chain seen in multiple myeloma. Secondary will be amyloid associated, more deposition in chronic inflammation, bronchiectasis, cancer, except in bronchitis. Okay, mutated will be seen in familial Mediterranean fever. ACAL, medullary carcinoma thyroid, ATTR or amyloid associate amyloid transthyretin, more or wild type deposition in systemic senile amyloidosis, mutated in familial amyloidotic polyneuropathy. A beta you will see in Alzheimer disease, A beta 2 microglobulin in dialysis related, and AIAPP in type 2 diabetes mellitus, and amyloid atrial natriuretic peptide in isolated atrial amyloidosis. Okay, so these are the types of amyloidosis. Now, which organ is getting involved and where it is getting deposited, we will see. So in the kidney it is going to deposit in the mesenterium. Okay, so in the kidney it will in kidney it will deposit in the mesenterium. Okay, then in the heart it is going to deposit it in the subendocardial location. Okay, so overall most common site of deposition will be kidney, but overall most common site of deposition in old age will be heart. Okay, in the liver it is going to deposit in space of Disse. Okay, if it is depositing in the red pulp of spleen, it is known as lardaceous spleen. Okay, if it is depositing in the white pulp, that is known as sago green spleen or sago spleen. Okay, in the skin if it will deposit, it will lead to pinch purpura, small bleeding, so pinch purpura. In the GIT it will deposit, lead to organomegaly. Okay, in the joints if it will deposit, lead to the joint problem, so carpal tunnel syndrome, all of those will come here. And in the blood vessel it will be in the subendothelial region. Okay, so they will lead to deposit in the different areas. Okay, other than this you have to remember in the this GI, this amyloidosis will lead to organomegaly. Okay, in all places except in kidney. Okay, in kidney initially it will lead to increase in size, but later due to ischemia it will lead to shrinkage of the kidney. So in the kidney it cannot lead to organomegaly or decreases the size due to those problems. Okay, in the tongue macroglossia, all of those things happen, except in the kidney it will not increase in the size. Initially it will increase, but as deposition will be more, the ischemia and trauma to the injury kidney will be more, so the size will be started decreasing. Okay, after that how we will diagnose? So if we will do cross examination, we will see Bexy kidneys. So here you can see these kidneys, how much Bexy they are. If here we will put Lugol's iodine, they will turn into violet color. So these will show the confirmation of our amyloid. So amyloid will deposit here. Okay. In the microscopy, first stain is Congo red. Okay. So if in light microscope we are seeing this will look like salmon pink color deposition extracellularly. Then if we are seeing under the polarized microscopy, it will look like apple green birefringence. Okay, so apple green birefringent. So here you can see this is our light microscopy, and this is our polarized microscopy. So this is our Congo red stain. Okay, then thioflavin T. Whenever we are using this stain, we have to use UV light. Other than this, we can stain with methyl violet, crystal violet, and these are also pass positive, means they will give pass will give them pink color. Other than this, in the electron microscopy, if we are watching the seeing under electron microscopy, they are non-branching filament, means these are straight filaments. Okay, they don't have any branch, and their diameter is 7.5 to 10 nanometer. Okay, so this will be the diagnosis under the electron microscopy. For the confirmation, we are using X-ray crystallography, where we will find beta plated sheath. If we want to check the extent of amyloidosis, then we will do scintigraphy. If they will ask you from where you will take sample, so we can take sample from the abdominal wall. Okay, after that we can also take them from the rectal biopsy. Okay, so abdominal fat aspiration we can do rectal biopsy, and here is the electron microscopy image of these. So you can see these are the fibers of amyloid, or if we will see in x-ray crystallography, we will see them in beta pleated sheath. Okay, so here we have finished almost all our all in cell injury. Okay, plus inflammation, cellular aging, and immunology. Almost we have finished half of general pathology. Only few things like genetics left. So in genetics, if you know, you have to remember all the examples of inheritance, and neoplasia left. So okay, so tomorrow, maybe tomorrow we will finish all these two chapters, and if we will have time before the that test, then we will also finish our systemic uh, pathology. Okay, so if you have any doubt, you can ask me. Okay, thank you for the joining. Okay, thank you so much. Okay, I will send you after 10 minutes. I will share.